distinguished guests, esteemed participants, ladies and gentlemen, it was with Johann Sebastian Bach's second suite for cello, played by the young Michalis Tsurekas, here, thank you very much, that we welcome you to this historic building, the Old Parliament of Greece. One of the great cellists of the 20th century, Mislav Rostropovich, had said that when he started learning the cello, he fell in love with the instrument because it seemed like a voice singing the infinite beauty of music. The music which, according to Plato, has a way of seeking and finding the innermost corners of our hearts. For a few hours, the Old Parliament will host a unique scientific meeting of the heart. We will highlight the pioneering work of 7 wise cardiac surgeons and honor their contribution to the advancement of science. Consequently, with the contributions of 7 leading scientists of the younger generation, we will complete the inspiring journey of cardiac surgery from the past to the present and examine the prospects for the future. Finally, through dialogue and exchange of ideas between the 7+7 and the audience, we will cover the totality of the issues involved in dealing with the modern scourge of our time, coronary artery disease. And now, will the President of the Organizing Committee, Mr. Sotirios Prapas, be kind enough to come to the stand? Mr. Prapas.
Thank you very much that you are here with us together to honor the 7 wise men of the 90s. Dear colleagues and friends, we warmly welcome you to the historic symposium 7 Wise Cardiac Surgeons of the Golden Decade of the 90s that we proudly organize in the imposing space of the Old Greek Parliament, an event dedicated to those who shaped modern cardiac surgery through the innovations and their dedication to progress. Please. During the 90s, all these 7 wise men inspired my course, and they were in some way my teachers. Years later, I stayed beside them, advancing the op-cab to the aortic off-pump using the Hellenic pie graft technique. All the time there was something inside me saying that I have to honor all of them for everything he have done and for the whole help he gave to me. Welcome, my friends, and I suppose this symposium here will be the beginning of a worldwide symposiums honoring you, and for us, the Greeks, is very important because we communicate this event with the ancient period and the 7 wise of the ancient Greece. Welcome again.
Thank you, Mr. Prapas. And now let us watch a short video about this historic landmark of Greece, the second Parliament, the Old Parliament building. The Old Parliament of Greece. The neoclassical building of the Old Parliament is directly linked to the history of Greece. The Greeks, after 400 years of Ottoman occupation, began their liberation struggle in 1821. With the help of the great forces of the time, England, France, and Russia, they defeated the Ottomans in the Battle of Navarino in 1827 and gained their independence. For the organization of the Greek state, the great forces imposed a monarchical regime by appointing as king of the Greeks the 18-year-old Prince Otto, the second son of the Philippine king of Bavaria, Ludwig I. Otto married Amalia in 1836, and the couple settled temporarily in the Vuros house, while at the same time the construction of a palace begun by the famous Bavarian architect Frederick von Goerdner, designer of the Hermitage Museum in St. Petersburg. Otto and Amalia settled in the new palace 6 years later in 1842. On September 3, 1843, the people and the army demanded from Otto a constitution and an end to the absolute monarchy. Gathered in today's homonymous Syntagma Square, they achieved the beginning of the parliamentary life of our country. With the establishment of the constitutional monarchy, there was an urgent need to find a suitable place to house the national delegation in Athens, the capital of the state, in 1834. The former Kondostavlos house, built in 1833 in a large verdant garden in today's area of the old parliament, is chosen. The large octagonal banquet hall of the house was used for over a decade, 1843 to 1854, as a meeting place for the House and Senate. Unfortunately, in 1854, the first Greek parliament was destroyed by fire. On the same spot, a neoclassical mansion was founded in 1858 by Queen Amalia and began to be built according to plans of the French architect François Boulanger to house the Parliament and the Senate. After the eviction of King Otto and the change of government in 1862, and according to the Constitution of 1864, the body of the Senate was abolished. The plans of the building were modified by the architect Panagiotis Kalkos, with the main change being the abolition of the Senate amphitheater. The Parliament building was completed in 1875. On August 11, 1875, the official opening of the sessions of the Parliament took place with Charilos Trikoupis as Prime Minister. 60 years, the Stadiou Street building housed the turbulent political life of the country. In 1935, the Hellenic Parliament moved to the old palace in Syntagma Square, where it has operated ever since. The building of the old parliament was granted by decision of Prime Minister Eleftherios Venizelos to the Historical and Ethnological Society of Greece in order to house the National Historical Museum. The implementation of the decision was delayed due to World War II. Finally, the company settled in the mansion in 1960, and 2 years later, the new exhibition of its museum opened to the public in its final roof. The old parliament is an architectural jewel in the center of Athens. The magnificent conference hall is a place of historical memory, but also a home for events of historical and cultural content. The hall surrounding it housed the permanent exhibition of the National Historical Museum, while the upper room is a space for its temporary exhibitions. Today, Kolokotronis Square is dominated by the equestrian statue of the hero of the Greek Revolution, Theodoros Kolokotronis. The bronze statue of the commander-in-chief of the Revolution of 1821 is the work of sculptor Lazaros Sochos. It was originally located in 1904 on a small islet at the beginning of Kolokotronis Street. It was moved to its current location in 1954 during renovation works of the old Parliament precinct. Και τώρα περνάμε στην πρώτη συνεδρία, στην πρώτη session. And now we come to the first session with the theme, the second millennium, how the coronary surgery evolved. The moderators are Daryl Shore, consultant cardiac surgeon, professor of practice, congenital cardiac surgery, Royal Brompton Hospital, London, UK. Kosmas Iliadis, thoracic surgeon, director of thoracic surgery department, Υγεία Hospital, Athens, president of HCTSS. George Kochadakis, dean, medical school of the University of Crete, professor of cardiology, University General Hospital, Viraklion, president of the HCS. Kyriakos Anastasiadis, cardiac surgeon, professor of cardiac surgery, Aristotle University of Athens, director of cardiothoracic surgery clinic, AHEPA Hospital, president of medicine department of AUTH. Kostas Sioufis, professor of cardiology, University of Athens, director, first cardiology clinic of the National and Kapodistrian University of Athens, Hippocratio General Hospital, Athens, deputy president of Medical School of Athens, National and Kapodistrian University of Athens. Nikolaos Bonaros, cardiac surgeon, deputy director, cardiac surgery, Innsbruck University Hospital, associate professor, Medical University of Innsbruck. Athanasios Trikas, associate professor of University of Athens, director of cardiology, Clinic Evangelismos Hospital, Athens.
Good evening, everyone. I'm Dr. Iliadis, and on behalf of the Greek Cardiovascular Society, it's my pleasure to welcome you to this symposium. Innovations and technical developments, the contribution of the seven wise men, is the title of the lecture, which is going to be given by Dr. Patakos. Dr. Gregory Patakos is a well-trained cardiac surgeon in USA, and he works in Greece as a vice director of the first cardiac surgical department in Υγεία Hospital of Athens. He is also an associate professor in Medical School of Nicosia of Cyprus. Dr. Patakos, please. Grigori.
Thank you very much for the kind introduction, Dr. Iliadis. Thank you very much, Dr. Prapas, and to all of the organizing committee. It's a big honor to be here today to essentially give the first lecture of the day, and I have to admit, somewhat intimidating given the very impressive roster of speakers and invited guests, two of which in the United States have interviewed me for cardiothoracic residency positions. So thank you to all of you for being kind and lenient to me in the past. We'll have drinks afterwards, perhaps. So I would like to start giving you the innovations and the technical development. Some of these things to me were relatively new. Many of you were around, and many of you were actually the ones who developed them. So we'll see today. So this is the second millennium. So clearly cardiac surgery hasn't been around for 1,000 years, but we are now in the second millennium where these techniques are being performed. We can't talk about any coronary artery operation without referring to everybody's beloved Weinberg procedure, in other words, implanting the bypass graft into the myocardium. Everybody knows the Weinberg procedure, and it was essentially the beginning of the study of what would eventually become perhaps the most well-studied operation in the history of mankind. In the early 50s, we see the developments. We see Demikov in Russia, and we have dog models, Gordon Murray in Canada. All of these people are pioneers in developing their techniques. But this wouldn't have gotten very far without John Gibbon, who introduced direct myocardial revascularization without the use of cardiopulmonary bypass. The first surgeon to perform an anastomosis of the Rita to the RCA was Robert Getz at Einstein. And we have again here the outcome that essentially the patient died of an acute infarct 13 months later. And however, this was never clinically repeated. As we see with many fantastic ideas, both in cardiac surgery as well as in the rest of medicine, initial failures often stymie further attempts. However, surgeons who are younger, perhaps more bold, who have forgotten the failures that their forefathers had, come back and are somewhat more fearless and persist. In 1962, Pronin performed successful CABG on dogs using a suture technique and continuous autoperfusion so that coronary blood flow was maintained. We see here in 1963, Kolesov used a collapsible cannula in dogs to provide continuous blood flow while the anastomosis was being performed. We have Kolesov. These are names that everyone who has studied cardiac surgery knows. Look, in the 1967, published a paper with 12 cases of anastomosis of the lita to the circumflexor LAD, with the first case being performed February 2nd, 1964. The results of the first 33 patients were assessed much later in 1991. So we can see that at this point, cardiac surgery is in its infancy. And here are many of the developments, the original schematics. I have to give a big thank you to Dr. Prapas for providing a lot of this historical information. We see here in 1967, Kolesov performing his anastomosis, and you see here that it's an end to side. So here in the US, however, we see a commentary after Kolesov's report that says, the opinions concerning the management and surgical treatment of angina pectoris as expressed in this paper are at variance with the concepts of many surgeons in the United States. So while there is a Cold War that is about to start in the future, perhaps the scientific Cold War has already started. Transatlantic battles have persisted for many decades, and until today we see differences. We wouldn't be able to speak about coronary artery bypass, though, and as you'll see, there's a theme throughout here that a lot of the surgeons are coming from South America. We see here at the Cleveland Clinic, René Favaloro, 1967, performing the first CABG in which a saphenous vein was used as the graft. Numerous series followed. I trained myself at the Texas Heart Institute, so I can't not mention the Texas Heart Institute. Denton Cooley was still roaming the halls when I was there, and the feeling that a young cardiac surgeon gets running into him in the hallways cannot be described. We see here one of the authors is Dr. Ott, who I had the privilege of performing these coronary bypass operations with. Again, in a report in the Annals of Thoracic Surgery, 1975, placement of a CABG without a pump oxygenator with 63 patients. Left thoracotomy then in the 1970s and 1980s was beginning to be used, and we have the first reports, and here we see the big names of Benetti and Buffalo, and in the 1980s, South America and South American surgeons are pioneers in these operations. I have to throw out a little tidbit from my trip last week to Peru, being in South America for a medical mission with my good friend Aldo Rafael from Baylor University Medical Center in Dallas, Texas. And twice a year, my good friend Aldo goes down to Peru to perform minimally invasive cardiac surgery and help the people of his homeland in a very honorable work. It was my honor to be there with him. And when he was operating, and there were about 20 people around, the photo couldn't fit everybody, operating at him, I couldn't help but think of the photo below of Denton Cooley with about 100 observers. Rumor has it that there was a group from China visiting, and he said, throw everybody in the room. I want everybody to come inside at the same time. Made for quite a photo op. I also couldn't help but throw out this photo with Benetti and my father, Stratis Patakos, at Hygeia in the late 90s, teaching some off-pump techniques, which we still use to this day. As you can see, I think cardiac surgery, more than almost any other specialty, is passed down literally hand to hand. We see here Dr. Benetti, one of the 7. Forgive me my American bias. All of these surgeons are professors, but in the US, everyone is referred to as doctor, as that is considered to be the highest title a physician can achieve. So please pardon me, professors. So 1978 to 1984, this is the first presentation in Argentina. The criticism of off-pump here is that it's not possible to perform anastomoses on the posterior wall of the heart. It's restricted to the anterior wall. And when the heart is removed from the pericardial sac, the hemodynamic stability is not there that would be needed to construct the anastomoses. So in 1982, there were only 5 reports of off-pump coronary surgery. By 1992, there were 18. And in 1998, 18,423 publications. So this is outstanding. So here we see the expansion. You see all the papers by Professor Benetti. We have the golden area of the 90s with facilities for the expansion of CABG, pardon the spelling mistake there, multiple arterial grafts, mid-cab, hybrid cab, ob-cab around the world, and multiple composite grafts. Dr. Salerno here is one of the people I had the honor of interviewing for a position with at the University of Miami. He was a fantastic professor and a fantastic host, I may say. What happens in Miami stays in Miami, so I cannot divulge what happened the entire night. But we had a fantastic time, and his residents are to blame. So Dr. Salerno, as one of the pioneers, was visited by my father as well, Dr. Patacos, in Buffalo, as many other thousands of surgeons traveled around the globe to learn from Dr. Salerno his techniques on how to perfect off-pump coronary surgery. Professor Calafiore began using this force-link technique in 1995 to expose the lateral and inferior wall, expanding the ability to graft all of the vessels. However, really when one looks at what is the one facilitating technology that allows for the performance of off-pump CABG, it's really off-pump stabilizers and the apical suction device. This is really what allowed the expansion to a wider audience of surgeons. So as with many techniques, when they begin, only a handful of surgeons are performing these techniques, and gradually technical developments and technological innovation allows for these techniques to be adopted by a wider group of surgeons. We see here the use of TTFR in order to be able to evaluate these grafts, as well as the publication by Dr. Salerno of the gas jet that would allow improved visualization to perform these. Grafts used in the 90s were the saphenous vein graft, and you see all the innovators, Favaloro, Green, Carpentier, with the use of the radial, which we still use today in almost every CABG. We see Dr. Suma, who is performing the use of the gastroepiploic artery. Further publications by Dr. Calafiore. I don't mean to belabor this. Many of you lived these developments day by day and attended these meetings where this was going on. So for you, I think that the emotional aspect of the developments of cardiac surgery as your child that you yourselves reared so that somebody like myself could today inherit it, the younger generation, we do thank you. And I think that more important than all of these developments is the fact that that's what we're here to do today, is to thank Dr. Calafiore, Dr. Salerno, Dr. Pasquez, Dr. Torregrossa, all of the people that I see in the audience here today. Mid-cab had its evolution with minimally invasive techniques. Nowadays, we have the ability to do it video-assisted, robotic-assisted. Dr. Subramanian, pioneer on mid-cab, one of the 7 greats who we are very lucky to have learned from, all of us, some of us directly and some of us through his publications. We have here the last procedure, left anterior small thoracotomy with Dr. Calafiore, multiple publications. We have Dr. Benetti showing us a subxiphoid approach with mid-cab. We have Professor Angelini reporting the first use of hybrid coronary surgery in 1996, and to this day, I believe there's still an NIH ongoing trial either being completed or soon to be completed about the results of hybrid CABG. Bristol, here we have our very own Antonis Pitsis with Dr. Angelini. Many Greeks were quick to travel and learn from these initial greats on-pump versus off-pump. We began to evaluate which patients is it better to perform on-pump versus off-pump. Dr. Trehan here with his series of a 10-year period, 2,800 patients, and this is knowledge that he took to have essentially the first center in Asia with a large series of publications about neurological complications, renal complications, transmyocardial laser revascularization in the 90s. I think this was a big plus. TMLR, can we burn holes in the heart? Perhaps we can. I think that has some of these techniques fallen out of favor over other techniques that have taken their place, and technological innovation will never cease. So the op-cab versus on-cab debate is not yet over. Recently, I was at the American College of Cardiology in Atlanta a month or two ago, and this is still being debated. Today. I think the initial enthusiasm has given way to data, where we can now, as with every technique, not every technique is for every patient, we now have a better set of variables to define who the patients are that will benefit from this technique. However, we wouldn't be here today without the contributions of these 7 wise men. So as Dr. Favaloro said as well, surgery and percutaneous intervention will always be complementary techniques. And as our friends in interventional cardiology evolve their techniques, so have we, thanks to the evolution that the 7 wise men have provided for us today. Thank you very much for your time and attention.
Thank you, Dr. Padagos. Congratulations for the excellent presentation on the contribution of the 7 wise men.
Before introducing the next speaker, I would like, first of all, to thank Dr. Prapas for this kind invitation, but mainly to congratulate you, Sotiris, for this great idea, to be this great place and to organize this special event. Really, many thanks and many congratulations. It's my great honor to introduce the second speaker, who is Professor John Puskas. He is Professor of Cardiothoracic Surgery at the Emory University, Georgia, Atlanta, and he will discuss a very interesting topic, taking into account that off-pump coronary artery bypass graft is completed in technical development. So what should be the next? Professor Puskas.
Thank you so much for your kind introduction, and special thanks to Sotirios Prapas for a long friendship and a kind honor of the invitation to be here with you today. I was asked to address the topic of what to do with OpCab at this point, and it's unfortunate that Dr. Mario Gaudino is not able to be with us, so I was asked to combine his lecture on arterial grafting into this lecture, which seemed to me to be very natural, because I do believe that the next evolution of OpCab to overcome an early disappointment is to improve the operation by utilizing an all-arterial, no aortic touch technique. These are my disclosures. So the so-called disappointment of OpCab is that while some countries perform large proportions, even the majority of their coronary surgery by off-pump techniques, it has not become the preferred methodology globally. And that's despite multiple large observational database reports demonstrating risk-adjusted benefits of OpCab compared to on-pump surgery for multiple endpoints. But despite that, randomized controlled trials have not demonstrated a reduction in mortality with OpCab for the low-risk patients that are typically enrolled in those kinds of randomized trials. There persist concerns about completeness of revascularization and graft patency, or the precision of the operation, although expert surgical teams have demonstrated excellent OpCab outcomes, including completeness of revascularization and long-term graft patency. Importantly, few centers teach OpCab well. and few surgeons therefore learn OPCAB well. And this is the fundamental challenge we face. Because OPCAB is a more technically demanding operation than the on-pump procedure, and frankly, I think it's not reimbursed at a premium, and that interferes with its adoption. U.S. penetration of OPCAB reached about 25% about 15 years ago and has declined to about 12 to 15% presently. In fact, some conservative leaders in our field have suggested that OPCAB should be abandoned. But I don't feel that this hiccup in the adoption of OPCAB should prompt its abandonment, but rather should spur the evolution and advancement of the techniques. I think it is due to suboptimal technique, suboptimal teaching, and inappropriate patient selection for enrollment in randomized trials, and failure to evolve to routine all-arterial no aortic touch technique that explain this disappointment. So instead of abandoning it, let's refine, improve, and promote it. Let's not throw the baby out with the bathwater. This is a graph that we created at Emory University looking at about 15,000 off-pump and on-pump patients done concurrently at Emory. And you can see on the vertical axis the observed mortality rate, and on the horizontal axis the predicted risk of mortality. And you can see for those patients who have a low predicted risk, it doesn't matter whether the operation is performed on pump or off pump. Logically, the on-pump outcomes follow the unity line because the predictive algorithm is calibrated on on-pump surgical cases. But what is interesting is that you see as patient risk increases, mortality observed in the off-pump group does not increase. So if the higher the risk of the patient, the greater the benefit of off-pump bypass. And in fact, that mortality benefit of off-pump bypass only appears when the mortality predicted risk exceeds 2.5%, which is about the upper half of risk in the STS national database, for instance. So if one only enrolls patients in that red circle, it doesn't matter how many patients you will enroll in randomized trials or meta-analyses of randomized trials, you will not demonstrate a mortality benefit because there is none for low-risk patients. But it is wrong to conclude that off-pump bypass has no mortality benefit. That's wrong. It does indeed have a mortality benefit for higher risk patients, and surely we all agree that our patients are becoming more elderly and more frail and higher risk. And thus the rationale for all-arterial, no aortic touch off-pump bypass is very simple. We know that arterial bypass grafts offer better long-term patency than veins. We know that avoiding aortic manipulation greatly reduces risk of perioperative stroke and, in fact, death. And thus, all-arterial, no aortic touch off-pump bypass may offer the best long-term revascularization as well as the least perioperative morbidity and mortality. And I consider it state-of-the-art coronary surgery. So let's go over some of those data that support that rationale. You've all seen these slides from the Cleveland Clinic demonstrating that for survival and intervention-free survival, having 2 arterial grafts in the form of mammary artery grafts beats 1. And in fact, the same group demonstrated that through 20 years of postoperative follow-up, beta survival exceeded CETA survival. We looked at the same question at Emory University, stratifying about 30,000 patients who had had beta with diabetes, beta without diabetes, CETA, single internal thoracic artery grafting with diabetes, and CETA without diabetes. And importantly, and perhaps not surprisingly, the best surviving group were the patients without diabetes who received a beta. Amazingly, the patients with diabetes who received a beta operation outlived the patients who did not have diabetes but were given only a single arterial graft at the time of coronary bypass surgery. And that is the important comparison between the second and third lines there. Can you imagine any other therapy that we have in all of medicine that mitigates the longevity impact of diabetes? I'm unaware of any other. And the benefit of multi-arterial grafting has been known a long time, but was really impressively demonstrated in this publication, which I had the privilege of co-authoring with Joe Sabik and many others. This is an analysis of the STS national database including a linkage to the National Death Index that allowed long-term survival follow-up for patients who had had single or multiple arterial grafts. And this is over 1 million patients who underwent isolated coronary bypass surgery throughout the United States. And at 10 years, multiple arterial grafting was associated with improved adjusted and unadjusted, or risk-adjusted survival. And this applied to all patient subgroups except those who were really very impressively obese. That is to say, they had a body mass index greater than 40. So long-term survival adjusted risk, you see multiple arterial grafts beats single arterial grafts, and the gap widens over time. The longer you follow the patients, the wider the curves diverge. And if you look in the lower right group, you can see time-segmented analysis, and that benefit really begins to appear immediately, but is most pronounced during longer-term follow-up. Favoring arterial graft, multiple arterial grafts were favored in terms of survival for all patient subgroups, 2, 3, and 4 vessel, left main disease, and in all classes of ventricular function, including the very low EFs. It applied to both off-pump and on-pump surgery. It applied to all patient groups, although of course the younger patients benefited most. Only those patients who were massively obese did not benefit from multiple arterial grafting. And I think it's important to note in this particular analysis, and there will be more analyses coming from this data set, but this analysis included approximately half of those patients had mammary artery with a radial artery and veins, and the other half had 2 mammary arteries and veins. The mortality benefit applied to both mammary arteries as a second graft and radial arteries as a second graft. But importantly, although the summary emphasizes that we are seeing an uptick in adoption of multiple arterial grafts, and that's true over the last 5 years, the actual numbers are terribly low. We're at 12% now. That means 88% get a single graft. So we have a ways to go. Dr. Taggart is here, and he published this ART trial. I had the privilege of participating in this publication in the New England Journal. Importantly, in the as-treated analysis of the ART trial, patients who received multiple arterial grafts had better survival at 10 years than those who received single arterial grafts. They also had better outcomes in terms of death, stroke, and MI at 10 years. Now, why do many surgeons not do? In fact, the large majority of surgeons do not do multiple arterial grafting. Well, in terms of the double mammary harvesting, deep sternal wound infection is a feared complication, and it is in fact more common in patients who have double mammary harvesting, but that really only applies if the arteries are harvested in the conventional pedicled technique. Our Japanese colleagues have taught us that we can harvest them in a skeletonized technique and use the harmonic scalpel to do so with the least possible trauma to the chest wall. And when we do that, skeletonized beta and single ITA have a similar risk of deep sternal wound infection. And you can see that analysis retrospectively of the ART trial demonstrating the same effect. Skeletonized bilateral mammary harvest and pedicle single mammary harvest have the same risk of deep sternal wound infection. And that's because skeletonized harvest preserves the retrosternal microperfusion of the sternum and adjacent tissues and retrosternal blood flow. We also routinely include vancomycin paste to minimize the risk of deep sternal wound infection. I'm not going to show any surgical videos. The only technical tip I'm going to share is this one. Use the simplest thing that I know that reduces risk of deep sternal wound infection, which is to take vancomycin powder, mix it with a very small amount of plasmolite, make a putty out of it, and jam it into the bone marrow of the cut sternum at the beginning and then again at the end of the case. With this technique, with skeletonized harvest, and with figure-of-8 sternal wires, I have personally done 500 consecutive bilateral ITA cases without a single deep sternal wound infection. The large majority of those patients have diabetes. And I work in America. They're not thin. Interestingly, adding a radial artery graft to either single or double mammary artery grafts improves outcomes. And this is another analysis from the ART trial by Dr. Taggart. But adding a third arterial graft improves late survival, and that's been known for some time, as demonstrated by this meta-analysis by Mario Gaudino. And that drove this interesting meta-analysis that I had the privilege of participating in with Mario. I managed to get the authors of 6 independent, small, randomized controlled trials comparing LITA radial veins with LITA veins. We got the patient-level data, did a patient-level meta-analysis, and published this in the New England Journal, demonstrating that the addition of a radial artery to the ITA, rather than just veins, reduced risk of death and graft occlusion. Death, stroke, death, MI, and revascularization was less common at 5 years, and that was driven by the reduced angiographic graft failure in the radial artery group, and thus less repeat revascularization as well. Now, the Australians found something very similar in their national database that they share with New Zealand, demonstrating that a radial artery was about as good as an IMA and better than saphenous vein grafts in almost 1,000 angiograms at a mean follow-up of almost 10 years. None of this is new. We don't have Dr. Carpentier here, but he commented in 1973, I was 13 years old, and he was noting the simple fact that the important debate should not be between the radial artery and the mammary artery, it should be between venous tissue and arterial tissue. And that's because as early as 1970, we knew that neo-intimal hyperplasia threatened the longevity of saphenous vein grafts used for coronary bypass surgery. And that's because, as you can see in the upper 3 slides, the IMA is essentially impervious to neo-intimal hyperplasia, while vein grafts progressively develop thicker and thicker neo-intimal hyperplasia and subsequently close. This is an interesting, again, post hoc analysis of the ART trial demonstrating that risk of MACE increases with increasing use of vein grafts in that data set. Any vein graft is associated with an increase in death in that data set. The Australians have previously demonstrated the same thing, noting that for total arterial revascularization, survivals are better at 10 years than for anything less than total arterial revascularization in a data set of 65,000 patients. And here a more recent summary from the Australian data set, again demonstrating that total arterial revascularization beats non-total arterial revascularization. So I'm going to switch gears for a minute and talk about no aortic touch surgery. And I'm going to tell you that I think the biggest failure that we innovators in off-pump surgery, our biggest mistake, was to apply a partial occlusion clamp to the pulsatile aorta off-pump to construct proximal anastomoses, and then to imagine that that would be associated with a reduced risk of stroke. We thought that avoiding the heart-lung machine would produce a benefit in terms of stroke, but in fact it's aortic manipulation that should be avoided. The heart-lung machine mandates a certain level of aortic manipulation, but a cannula in the arch and a single cross clamp is more benign than 3 applications of a partial occlusion clamp to the ascending aorta in a pressurized and pulsatile aorta, because stroke is the Achilles heel of coronary bypass surgery. This is the Syntax trial at 1 year, 2.2% risk of stroke in CABG and 0.6 in PCI. The cardiologists were paying a lot of attention to that at 1 year. And in the Freedom trial, stroke rate was twice as high for CABG as for PCI among diabetic patients. There are documented and reliable strategies to reduce the risk of stroke. This is a paper that I published with my mentee, Michael Halkos, years ago from Emory, and demonstrating that avoiding touching the aorta at all provided the greatest reduction in risk of stroke. The observed to expected ratio was least for patients who had no touch on the ascending aorta. And that's been demonstrated elsewhere. Edelman and others have demonstrated that more than a decade ago, demonstrating that for anaortic compared to side-biting off-pump surgery or anaortic compared to conventional on-pump surgery, the anaortic surgery won. Now, Alexander Albert learned anaortic surgery from his mentor, Paul Sargent, in Leuven, Belgium, and took it to Germany, where he leads a large department, and he mandated that that department switch from a traditional on-pump surgical approach for coronary surgery to an all-arterial, no aortic touch approach, and in so doing, he was able to reduce the risk of early stroke by almost 90% in his own department. That benefit was seen almost exclusively in the reduction for early stroke, not late stroke, which is what you would expect by eliminating manipulation of the ascending aorta. I had the privilege of participating in this interesting analysis of about 40,000 patients were divided into 4 subgroups based on the kind of surgery they had with respect to aortic manipulation. The first group is an on-pump conventional operation. The second group was an off-pump with a partial clamp. The third group was an off-pump with a heartstring facilitating anastomotic device that is clampless. And the last group is the anaortic or no-touch aortic technique. This is called a network meta-analysis, and you'll see in the upper left of the slide that for the endpoint of stroke, anaortic surgery beat conventional surgery with a risk ratio of 0.22, meaning a 78% reduction in the risk of stroke with no aortic touch surgery compared to conventional surgery. Similarly, in the upper right, you see that for mortality, anaortic OPCAV was associated with a 50% reduction in stroke compared to conventional surgery. And for each of the other, you see that endpoints, anaortic OPCAV is at or near the pinnacle of the triangle, representing the best alternative therapy. Therefore, this is my favorite operation. Double mammary inflow and multiple arterial outflows. There are lots of different ways to do it, but that's the one we do most often, so we put it on the cover of this book that David and I published not too long ago. But that's not the only way to get there. Sotirios Prapas here in Athens has demonstrated the extraordinary utility of the pi circuit. It just happens to look like a pi symbol, which is a Greek symbol. We all had to memorize that as children. I remember the 3.14, etc. Now I've know someone who's similarly engaged with that symbol. And this symbol has been associated with the technique for over 3,000 patients in his own practice, achieving anaortic surgery and a reduction in the risk of stroke by 50%, very similar to what we saw in that other analysis we showed you. The recent EACTS guidelines have recognized that minimized aortic manipulation is key, that off-pump with no touch techniques is best for patients with significant atherosclerosis of the ascending aorta. And thus, in summary, I believe that surgical coronary revascularization must deliver the best possible long-term outcomes with the least possible perioperative morbidity and mortality risk. We know that all arterial grafting prolongs life. We know that beta and radial artery grafts are usually both better than veins for long-term patency. No-touch techniques by avoiding manipulation of the ascending aorta are associated with the lowest risk of death and stroke, and especially benefit the elderly, frail, and atherogenic patients that we operate on more and more commonly. This is a great meeting here today in Athens. I hope that you will consider joining us for our meeting of the International Society for Coronary Artery Surgery. Many of the wise men and the next generation are participating in the society, whose mission is to advance the state-of-the-art in surgical revascularization and to improve the quality of life and care for patients with coronary artery disease worldwide. Our next meeting will be this year in London. Thank you so much for your attention, for the honor of being here in association with the pioneers who have been literally my heroes for my professional life, and special thanks to Sotirios Prapas.
Thank you, Professor Kouskas, for your amazing talk and for your great personal contribution in the field.
Now, it's an honor and a pleasure for me to introduce Sotirios Prapas. You all know that he was the President of World Society of Cardiac Surgery, the founder and President of Euro-Asian Bridge, President of Hellenic Cardiac Society, and an ambassador of Greek cardiac surgery in international fora. He was also the man behind this 7 Wise Men initiative 20 years ago when he first organized the Prime event, and now he is organizing this excellent second event about the seven wise men of the 90s. So, Sotiris, the floor is yours.
Thank you, Kyriakos, and thank you, Dr. Puskas, one of the best surgeons in the world I met in my life, for giving me the opportunity to say that an aortic surgery is the best technique performing CABG in our specialty. I feel very proud, me and my cooperatives during the years, and I devote this presentation to them because that is now, which is now reality, started here in Greece almost in 2000, 24 years ago. In the ongoing debate between OPCAB and ONCAB, the prominent role of the aortic bypass seems to be recognized by both sides. Advantages, as you have heard already, lower incidence of neurological events. Here is our publication, which mentioned by Professor Puskas, so low possibility for stroke, 0.5, lower than PCI. And in this publication, you can see that the stroke incidence in high-risk patients for stroke is the lowest percentage between the other techniques. Also, delirium and cognitive dysfunction is the lowest, only 12.5% in aortic surgery. Of course, the multiple arterial grafting offers to the patient and allow us to perform an aortic surgery in cases with porcelain aorta, favors high-risk cases and octogenarians. This is some of our results. Primary endpoints, just 1.3 mortality, 0.65 CVA and AMI. The major physiological advantage of an aortic CABG is that all grafted coronary arteries are supplied with blood from Επτάς. The nitroxide. The Επτά is a drug-eluting graft that releases nitroxide, a potent protective factor that diffuses downstream. In addition to its vasodilatory and anti-proliferative effect on smooth muscle cells, NO also inhibits the adhesion and aggregation of platelets and the interaction between leukocytes and endothelial cells. You can see here a very interesting finding. Measuring the nitroxide in the anterior intraventricular vein before and after lead anastomosis, you can see the statistically important increase of the number of millimoles, 44 towards to 70. That means the Επτά has a high percentage of producing NO, and therefore this NO is going to the coronary band. You can see here after years how the coronary arteries show no progression of atherosclerotic disease. But the problem is how to do an aortic coronary surgery. As you can see here, you have to reach the highest step following the other steps from the beginning. I started that on 1997 in Onassis cardiac surgery. Yorgos Stavridis here gave me the opportunity to start, but God gave me the inspiration to create a secondary arterial graft following a natural way, because in all organs and extremities there are two or more circulation, and the heart has just one, and we produce an artificial one, but natural. In an aortic surgery, ETAs are the blood sources, and there is not any touch of the aorta. All the composite conduits, reconstructions, extensions were built before the revascularization, in which we use also sequential grafting. From January 2001 to 22, almost 4,000 patients received this technique. Mean anastomose 3.1, and the grafts are there we used. 2/3 almost had a double inflow of mammaries, and 1/3 just one. This is cases with double inflow, usually arterial grafting with reconstructions on the left side and extension of the proximal aorta with SVG. Double inflow P-circuit cross, single inflow, different arrangements like a trifurcation we announced on 2002, almost Y graft and sequential, C graft, all the letters of Greek alphabet. And now the I graft. In 700 patients, a piece of saphenous vein graft was used as an extension of a Y from, or a Y from the ETA. We included these patients in our analysis for many reasons. This is the sync flow, SVG to RCAs as Y graft from RITA, and also towards to LAD and RCA. We published that, and recently we have done with the help of Antonio Calafiore, who found in our data many interesting things, and he was concentrating on prove that the saphenous vein graft connecting to a piece of IMA works as artery. And you can see that here. We have done this study comparing SVG from IMA and SVG from aorta. And we found an extremely statistically important difference between the two methods, favors the RITA connection. And as you can see there is something, another phenomenon as well. You see the diameter of saphenous vein graft 24 months and 123 months later in two cases. And you will see that from 3.4 became 2.7. In the same way, Dr. Huang, he realized that during the years, this saphenous vein graft connected to a rima or a lima, diminishing the diameter because probably of an arterialization of the saphenous graft. You can see the difference. Almost Lobo Pillow realized the same things. And recently we are doing another study comparing the two groups, as I mentioned before, just to find how nitroxide supplementation improves the outcome. And you will see after the publication how is the difference. Just a few words about our results. Briefly, early results, very low primary events, only 0.9 death, 0.4 stroke, MI, PTCA, repeat revascularization, and adverse events. This is the 20 years survival in our patients, which is independent from single or double source of blood through the mammaries. I have to say, as a conclusion, that aortic CABG reduces postoperative stroke rates, and this benefit is more pronounced in high-risk subgroups. The Επτάς are the source of blood, and the coronaries benefit from the release of atheroprotective substances, mainly NO from the Επτάς. Performing an aortic CAB requires some creativity. Since all additional conduits are connected to Επτάς, the SVG can be used freely as it behaves like an arterial conduit and not like a venous one, directly connected to the aorta. When the SV is connected to an Επτά, the NO goes through the saphenous vein, diffuses to the ECs and the SV layers, eliminating or limiting the problems associated with NO deficiency. This seems to be the best strategy to improve the patency rate of the SVG that remodels in the meantime to acquire properties similar to the arterial conduits. I forgot to put thank you, but I have to say it from my heart. Thank you.
The next speaker is Dr. Gianluca Torregrossa from USA, and Dr. Torregrossa is a cardiac surgeon, director of the Robotic Coronary and Coronary Vasculation Program at Lankehoe Heart Institute in Philadelphia, the USA.
Good morning, or actually, good evening. Good evening, everyone. Thank you so much for this invitation here today. My name is Gianluca Torregrossa. As mentioned before, I have been mentored by several of the people inside this room, and I think my value here today is not only to present about robotic cardiac surgery, but is also to show to the neck that there is a next generation of coronary surgeons, a next generation of people that are taking all of the teaching that all of the wise men and all of these leaders in the world and in the field of coronary surgery have given us, promoting of pump, promoting multi-arterial, promoting an aortic, and trying to push again further, one further step, the technology and the advancement and the knowledge that all of you have contributed with. I see the sliding going up here, but not on the screen. My major deep interest, and I can start just for a matter of time, try to work on it, is what I call robotic bypass surgery. Robotic bypass surgery means taking one or two mammary arteries in a complete, using this robotic platform in a complete closed chest environment, and using this artery to complete an anastomosis or two anastomoses to the best target of the left coronary system. This can be done as an isolated procedure or in combination with coronary stents, in what Dr. Angelini has firstly described as a hybrid procedure. The value of a robotic platform respect of the traditional way of performing a thoracotomy are several. First is the ability to view properly the details, with details, the anatomy that we are dealing. I don't have any disclosure, and as you see, I've been trained by Dr. John Pascas. I feel to be one of his mentee, and he will be forever one of my most important mentor, influential person in my professional life. I love these slides because I made these slides around 2 or 3 years ago when I was speaking at EACS in Milan. But I found that this slide is conceptually wrong. And it's wrong because I was trying to depict the fact that we need to move towards multi-arterial off-pump anaortic. But the reality is that we are not really dealing with only one line, but we are dealing with a circle. And that means that we need a generation of cardiac surgeons capable of performing any type of coronary intervention. One day you need to do an on-pump CABG with a mammary and 2 veins, and maybe treating atrial fibrillation for that patient. There is a role for patients who need anaortic total arterial bypass grafting via sternotomy, and you need to be facile and able to perform a minimal invasive technique in the form of robotic or TCAB. So it's not that robotic CABG is here to take over, to compete against sternotomy CABG, but rather we need to create a generation of coronary surgeons capable of performing any type of coronary intervention on our patients. These are my results. As you see, I perform around 50% of my procedure, 55 still via sternotomy in the coronary world, and 40% as robotic. The value of robotic is summarized in these slides. This is what most of the surgeon sees. Advance a smaller amount of patients that receive coronary intervention are devoted to receive a bypass grafting and are the one with the highest syntax. But as soon as you start a minimal invasive or a robotic program, you start to see the shifting towards something that looks like this. Patients get to refer more to you as a surgeon, even for isolated coronary disease, because now the cardiologists value the Lima to the LED graft. They believe in the Lima to the LED graft more than what we think. And with the aim of hybrid procedure, you can treat patients that otherwise would have received multi-vessel bypass grafting. And the reality is that for how much we know that coronary artery bypass grafting is the best treatment for coronary artery disease, and this is mostly because of the ability of bypass to stabilize the secondary plaque. Yet in the era of drug-eluting stent and FFR PCI, yet still CABG is the best and most superior treatment. But despite that, and this is one of the cases that I took years ago from Mount Sinai, despite that, a lot of patients with triple vessel disease still receive multiple stenting rather than receiving bypass grafting. So the real life of multiple vessel disease is that they don't receive a sternotomy CABG, but they receive multiple vessel PCI. If you have a program of minimal invasive coronary bypass grafting, you will see some of these patients coming your way through. You offer a Lima to LED, or you offer a Lima to LED and a Rima to the OM, and then there is a room for stenting the RCA. These are potential patients that can be treated in a hybrid or in a robotic way. And I will show you here is a picture of what the hybrid coronary vascularization is, or the double bypass, so an advanced hybrid where 2 mammary are used. Both of the mammary are taken robotically via 3 small incision in the left side of the chest. This is the device that we use, and there is a video here if it's possible to be played. And if it doesn't play down there, yeah. You see that is inside the operating room. Your hands are away from the chest of the patient. There is no wound infection. You are taking down 2 mammary artery with a closed chest. This is my time at Mount Sinai with Dr. John Pascas. You see the left side of the chest, the trocar, and the insertion of the instruments, and you can take 2 mammary artery in all comers. Any patients with a high BMI, high HbA1c, there is no risk of wound infection because there is no sternotomy. These are some of the incisions that I've done with a thoracotomy in mid-CABG, but I have decided to abandon this way and try to go for a more advanced level. Why is that? Because when you perform a robotic mid-CABG, or in general a mid-CABG, the possibility to take a right internal thoracic artery are limited. It's difficult to take the right internal thoracic artery via thoracotomy. Possible, but not for all patients. When you deal with high BMI, when you deal with patients with difficult chest anatomy, with pectus, it's complex to do so. And instead, enriching the lateral wall from a thoracotomy become difficult. You want to maintain the thoracotomy small for the principle of a minimal invasive procedure, but to expose the lateral wall, you need to enlarge this thoracotomy. So, mid-CABG, you see this is a Lima to LED in my OR. I took down the mammary via thoracotomy and I do the connection as previously described in a minimal invasive setting without rib spreading. This is a great surgery, this is a great procedure, and I'm a big supporter of it. But I think we can imagine a better future. And the better future is what we call TCAB. You see, we do the anastomosis with a robo. Why is that? The value is that you can see beautifully your targets. You can bypass any type of targets, and you can reach now your lateral wall very simply. You don't have to over-push to bring the heart towards the opening of your thoracotomy. You just need to stabilize the coronary and sew the coronary together with your bypass. So you enhance the possibility to perform multi-arterial, aortic, as Dr. Prapas just said, bypass. Lima to the LAD, Rita Y-graft to the OM, or Lima to the LAD, Rima in situ to the OM. Remember that when you touch your chest, the two mammary arteries are very close to each other if you don't open the chest. We have always, as a cardiac surgeon, the worries of what we do with the Rita. And we have these worries because when you are in an open sternotomy, you move the Rita away from your heart and you are always stretching this Rita to reach your final destination. A good technique is an eye extended graft that I personally use and learn in my training. But definitely when your chest is closed, when you are using a robotic platform, you don't need to do extension. You can use the Rima and reach easily an OM1 or an OM2. To reach an OM3, you can even do a Lima to the OM3 and a Rima to the LAD. So if a robotic mid-CABG is basically landing your airplane on an helipad. This is what mid-CABG is. With the TCAB, instead, you can really perform multi-arterial bypass grafting in a closed chest. I try to skip these slides, but here the concept is simple. There is a signal in literature that two mammary arteries, even in incomplete revascularization, are better than anything else. Look these slides from Cleveland Clinic. Beta and IR, you see incomplete revascularization, is better than CETA with complete revascularization. What does it mean? It means that when we open the chest via sternotomy, the era of doing one mammary and 8 bypass on a vein, CABS times 9 or CABS times 7, and measuring how good we are doing for our patients by the number of bypass that we are doing, that era is gone. In my opinion, in the current era of medical therapy, guideline medical therapy, the best things we can offer is more multi-arterial bypass grafting. And it doesn't really matter to bypass every millimeter bypass or millimeter vessel with a vein. And this has been showed even by the group of Emory University. Multi-arterial is better than complete revascularization. And again, by Faisal Bakin at Cleveland Clinic, and they showed that the only thing in 20 years survival was that the two mammary arteries were reaching the best targets of the coronaries, defined as the LAD, and as a second target, a target that reached at least 75% of the muscle of the heart. So once you do that, the fact that you bypass or not bypass with a vein, with a radial, or no bypass at all, the rest probably doesn't have a huge impact. And this is particularly important not for the 55 years old that should have complete revascularization, but for the 70 years old. Once you give him two mammary arteries in a closed chest via robotic, you can treat the right with a stent, or you cannot treat and just give medication to the patients. Here is my setup. I try to go fast. You see, this is my setup. I want to show you just the videos. This is a video that should hopefully play. You see, you've seen before some of the coronary anastomosis. I try to take like 1 minute of this video, and then I'll show you some patients, because I think that has more sense. You can skip a little bit, like 20 seconds of the video. so we can try to, if I have the opportunity to do it from here, will be great, but yeah, here. We enter with a device. You can skip other 20 seconds. Can you skip 20 seconds of this video? Can you do it? So I just want to be respectful of the time. Yeah. Go there, beautiful, beautiful. You see now the stabilizer is on the coronary, is a Medtronic stabilizer. Unfortunately, we don't have a robotic stabilizer. Hopefully, we will have it soon if more people join us in this concept. And again, we are not here to say robotic bypass is for everyone. I perform a lot of sternotomy bypass, and I think it's very important that someone is capable of performing every type of bypass. But it's important that there is a generation of coronary expert, coronary trained individuals capable of performing any type of coronary intervention. And here you see it's elastic. You are all familiar with the off-pump technique. You just do everything. In a closed chest, you can do a Y graft. You can do a sequential grafting. You can do everything, and you can skip other 20 seconds, and then I'll show you the final, even more, skip more, yeah. We are closing, skip more, other 20 seconds. This is the opening, and we start the sewing. You see there is a shunt inside. Look at the view that you have. Like I can have a resident sewing this coronary. It's very controlled, it's very clear, the shunt is open, you can skip other 10 seconds. You take the mammary and you basically look the mammary. You see how nicely, this is a 9-0 needle mounted on a 7-0 suture. You do your anastomosis, you complete your anastomosis, then you insert a medicine probe and you check your flow. This is exactly the same type of surgery that all of you will do in off-pump, and if you're facile with off-pump, any trained surgeon can do this one. This is not complicated, just require a little bit of dedication as everything. You see very well everything, every part of the anastomosis, the back wall. And I show you 2 more pictures and then we finish. You can play this video. Please, the first one is T-shirt on. The other one first. Yeah. So this is patient's postoperative day 1. There is volume or no? Hopefully.
This doc here, awesome freaking job. He did a total robotic bypass with left arterial appendage. And
I did
yesterday. I came in. All I can say is that I'm ready to go home today. So thanks.
How much you're walking? You're doing.
No, look. I feel great. I feel like
you can. Yeah. Excellent.
Hey, my name's
All right, Doc. I'm feeling a lot.
We are going here.
So, good afternoon.
Hi.
I'm happy to see you here in the office, and I will ask you some questions about you and your surgery. So, what type of surgery you received?
I had a T-cub bypass.
Fantastic. And when did it happen? Which day?
On Monday. This past Monday.
And
Today's Friday.
Today's Friday. How many days have you been in the hospital after the surgery?
Less than 24 hours after the surgery, I was discharged.
Amazing.
Yeah, that's what I think too.
And how did it go the first day when you were home?
It went really well. I actually felt really good when I got home.
How do you feel right now? Do you have pain? Do you have
just very minimal pain in where the chest tubes came out.
And you're
So the next one was an 80 years old, the 30% EF, just to show you this is feasible, this is possible in all of your hands. You guys are fantastic surgeons. Just be focused and dedicated. There is a huge patient population out there that can receive 1 or 2 bypasses, currently are receiving multiple stents, or are receiving a sternotomy and 2 bypasses and with a mammary and a vein. And you can do all of this with patient that goes home the next day or in 2 days back to their normal life. The reality is that we need to work together to make this happening. We need a dedicated coronary surgeons capable of performing any surgery. Robotic is not here to eliminate or to compete against a sternotomy CABG, but is here to compete against a multivessel PCI and to offer another tool in the hands of the coronary expert to treat better patients with the best conduit that we have, that are the mammary arteries. Thank you so much. It's a great honor for me to be here.
Dr. Grossa, maybe it was an introduction to the future.
Just take a moment before I introduce the next speaker just to say how much I'm honoured to be invited to this event, particularly as I'm a congenital cardiac surgeon and maybe suffering a bit from imposter syndrome. So the next the next surgeon I wish to introduce, who's already on the podium, is Professor David Taggart, Professor of Cardiothoracic Surgery at Oxford University. David is co-author of over 300 publications, and he has dedicated his energies and his intellect to teasing out the data of published work and that of his own to establish the best treatment for patients with coronary artery disease. And he also uses his eloquence to convince us of his own opinions. David.
Thank you, Darrell. So good evening, ladies and gentlemen. I want to start by thanking Dr. Prapas for the enormous privilege and honour of coming to this symposium to honour the 7 wise men of cardiac surgery, all of whom you have seen deserve that accolade enormously. I also had the fortune to work with Dr. Prapas at the Brompton more than 30 years ago, and I've maintained a lifelong friendship with him, and he's a man of enormous generosity of spirit and hospitality. So thank you very much for the invitation. Now, I have 10 minutes to talk about why we should still be doing CABG rather than PCI. So you've heard about the great technological advances of how to do CABG, but what I'm going to show you in the next 8 to 10 minutes, why we should be doing CABG rather than PCI. I do have some conflicts of interest. Clinically, I'm a cardiac surgeon, so I do support CABG, and I do have some commercial interests, but none of them relevant to this presentation. So I'm not going to show too many slides tonight, but of the ones I show, there are some that I think are really important. And this is from an article by the former editor of the New England Journal of Medicine, Marcia Angell, about drug companies and doctors, a story of corruption. And I think as I go through my talk, you will see how relevant this is to the issue of PCI and CABG. And she said, conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. I would add 3 further cautions to what Dr. Angell said. When you look at trials of PCI and CABG, first ask yourself who were the patients in the trials, because they are usually not representative of real clinical practice. The second thing I would say to you is look at the duration of follow-up. It must be a minimum of 5 years, and even then it's an interim analysis, because the longer you follow up any trials of PCI and CABG, the benefit of CABG, particularly in terms of survival, becomes accelerated. And you will often see in trials that the CABG patients receive substantially inferior medical therapy compared to the PCI patients. And my final general tip to this, if you're reading a paper or asked to review one, never read the text. Look at the data, look at the results, and you should then know what the text says. And I say this because, as I will show you in this talk, much of what is written in the papers of PCI and CABG have a very high PCI bias and do not always reflect the data. So I'm going to show this from 10 years ago, the most definitive trial ever done of PCI and CABG. And it was unusual because of 20 previous trials. This was the only one that tried to be a relative all-comer study. And it showed that if you randomized patients with 3-vessel disease, CABG resulted in a very significant reduction in death, myocardial infarction, repeat revascularization, and no increase in the risk of stroke. And the other thing we saw from this trial was that depending on the complexity of coronary artery disease, as you went from low to intermediate to high, the survival of advantage of CABG accelerated. So in the intermediate group, it was 7% at 5 years. In the higher severity disease, 9% at 5 years, and accompanied by marked reductions in myocardial infarction and repeat revascularization, and no difference in the incidence of stroke. And when you follow these syntax patients out to 10 years, you can see that that survival benefit of CABG continues to increase and accelerate with time, so that by 10 years, there's a 40% difference in the risk of mortality. And this also applies to patients who do not have diabetes. This is a paper by 14 of the most prominent interventional cardiologists comparing PCI and CABG and showing this accelerating survival advantage of CABG out past 5 years. And these cardiologists concluded CABG as compared with PCI with drug-eluting stents significantly reduced the long-term risk of mortality in non-diabetic patients with multivessel coronary artery disease. Now, the syntax trial is often criticized now because people say it didn't use the newest, best drug-eluting stents. So the FAME trial, a randomized trial, 1,500 patients undergoing PCI or CABG, and this time PCI was done to the very best performance possible. All patients had FFR and all had the best available drug-eluting stent. Now, 83% of these patients had low syntax scores below 33, and the primary endpoint was 1 year of MACE, which was death, MI, stroke, and repeat revascularization. So the conventional way to assess a trial. And the results at 1 year were significantly better for CABG, so PCI did not achieve non-inferiority. So what happened at 3 years? So the cardiologists published a paper, and they showed the main outcome a hazard ratio of 1.3. So PCI was not as good as CABG, but they said this was not a statistically significant difference. But if what they did to achieve this result was they changed the primary endpoint of the trial. The primary endpoint was MACE, including repeat revascularization. And if you look at the primary endpoint, you can see it was 18.6 for PCI, 12.5 for CABG. So this showed at 3 years, CABG was highly superior to PCI. But the cardiologist changed the primary endpoint to just death, MI, and stroke. Now, in my whole professional career, I've never seen a study where the primary endpoint has been changed. There were 40 authors. There were further statisticians, reviewers, editors for circulation. Were they all asleep? Did no one recognize they changed the primary endpoint? Or did all of these people agree to remove the primary endpoint to make PCI appear to be non-inferior to CABG? This goes back to the warning of the editor of the New England Journal of Medicine. You cannot trust what you read in clinical trials. If you look at diabetes, very straightforward. Look at the biggest trial done, the FREEDOM trial. CABG is a clear winner, even in patients with low severity coronary artery disease. And you can see that at 8 years, the survival benefit for CABG is increasing. Also, they showed in this paper, and it's important for your multidisciplinary team meeting, that at every level of syntax score, CABG was superior to PCI. And the authors concluded CABG should be the preferred method of coronary revascularization, regardless of the complexity of coronary artery disease. And this was written exclusively by cardiologists. If you go to patients with ischemic cardiomyopathy, the most definitive trial is STITCH. It shows that after 5 years, there's a survival advantage for CABG that continues to increase out past 10 years. And another very important lesson for this audience today, there's only been one randomized trial recently published comparing PCI to optimal medical therapy in patients with ischemic LV dysfunction. 700 patients, ejection fraction below 35, and what happened with PCI versus optimal medical therapy? No advantage whatsoever. No difference in the primary outcome, no difference in secondary outcome, no difference in death, myocardial infarction, hospitalization, or repeat revascularization. So we can say from this absolutely conclusively that there is no benefit of PCI in ischemic LV dysfunction in contrast to the benefit that CABG has. I'm just going to finish briefly by showing you another disruption of medical trials. This is the XL therapy, a trial of almost 1,800 patients with left main of syntax scores below 32. These patients were relatively young, mean age of 66, and they had low or intermediate severity left main disease. In other words, if they got the proper treatment, they should be alive 15 to 20 years later. But what did we see in XL at 5 years? A statistically significant increase in mortality of almost 4% and rapidly accelerating in these young, otherwise healthy patients. Now, when this paper was initially reviewed by the New England Journal editor, he wrote, "The finding of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the report of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph." But that didn't happen. The paper was resubmitted without any changes and accepted for publication. And I was the chairman of the surgical trial, and because of this, withdrew from the final publication. The other thing the XL trial did in terms of manipulation of a trial, in terms of looking at myocardial infarction, it used a new biochemical definition of MI, never tried, never tested before, and although they had the data for the conventional outcomes of CK-MB and troponin, these were not published. And this was enormously important to the clinical outcome of this trial, because if you change from the new biochemical definition to the conventional definition, the incidence of myocardial infarction in the CABG group dropped by 77%. And if that had been published in the original trial, the XL trial would have said CABG is highly superior to PCI in patients with left main disease. So this is going to be the final slide I show in terms of time. There are 3 reasons for a persisting survival benefit of CABG over PCI. The first is that anatomically, atheroma is mainly located in the proximal coronary arteries. So if you place a bypass graft to the mid-coronary vessel, you achieve 2 effects. You make the complexity of the proximal culprit lesion irrelevant, and over the longer term, you offer prophylaxis against new progressive coronary artery disease. In contrast, PCI only treats suitable localized proximal culprit lesions and has no prophylactic benefit against new disease. So every time the cardiologists say, you can ignore everything in the past because we have a new stent, they fail to understand this basic point. The second thing is, as shown by Tom Musher in the New England Journal of Medicine 3 decades ago, the internal mammary artery elutes nitric oxide into the coronary circulation and reduces the risk of further disease development. In contrast, a drug-eluting stent impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a pro-thrombotic environment. And the third fundamental difference is that for most patients undergoing PCI, it means incomplete revascularization, and this has been repeatedly shown to correlate with subsequent mortality and morbidity. So, when the cardiologists initially did a trial of CABG versus balloon angioplasty, CABG was better, and the cardiologist said, that's because we didn't use bare metal stents. So when they compared CABG to bare metal stents, CABG was still better, and the cardiologist then said, that's because we didn't use drug-eluting stents. And when they compared drug-eluting stents to CABG, and CABG was still better, as I've shown you today, they say, we used the wrong kind of drug-eluting stent. The cardiologists are focused on the stent, but if you understand these three pathophysiological mechanisms, which to be critical of a significant number of cardiologists, they don't follow this, they just keep saying, we've got a new stent. On that point, I'm going to conclude my talk. I'd like to thank Dr. Prapas and the organisers again for the great opportunity and privilege of being here, and thank you, the audience, for your attention. Thank you.
First of all, I would like to thank Dr. Prapas for this kind invitation to co-chair this session and for the organization of this 7 Wise Men Symposium. Next speaker is Dr. Kanakakis, the past president of the Learning Society of Cardiology and director of the cardiology department in Dinan Hospital, Athens, who will give us the presentation entitled Interventional Myocardial Revascularization, the cast has already been conquered.
Good evening, dear Chairman, dear colleagues, ladies and gentlemen. In the next few minutes, I will discuss interventional myocardial revascularization. The cast has already been conquered. I concentrate mainly in the evolution of PCI and not to present trials of three-vessel disease or left main, etc. The major advancement and current practices are balloon angioplasty, introduction of stents, imaging and diagnostic modalities, and emergency techniques. Historically, Andreas Grutzing performed the first successfully percutaneous transmulinal coronary angioplasty in 1977, and this is the founder of the interventional cardiology, but there's two drawbacks of the PCI. The first was the high restenosis rate and the elastic recoil of endothelial cells. So, introduction of stents in 1980s and 1990s, and the first stent was the bare metal stent, with the major drawback was the restenosis varied between 20 and 50%. The other problem for bare metal stent with the stent thrombosis, and this lead, can you put the slide here? And this led to the first generation drug-eluting stent. Tests were introduced in the early 2000s to further reduce the rate of restenosis and releasing sirolimus or paclitaxel drugs inhibit cell proliferation. The problem with, you can see them in the Ravel study, and in comparison with the balloon angioplasty, we have less restenosis rate and less thrombosis. The problem with the first generation drug-eluting stent was the late clinical events due to late stent thrombosis, and for this reason, second generation tests introduced in the interventional cardiology field and improve the initial design with thinner struts and more biocompatible polymer, leading to better outcomes and fewer complications, for example, less late stent thrombosis. This is the stent that we use more in the interventional field today, but now we have the third generation stent. It's not going. Third generation stent with fully biodegradable polymer, which varies, the absorption varies between 3 and 15 months. And there is different shape and different material for this kind of stent. This is the stent now prevalent in interventional cardiology. And the reason for this was to deal with high sensitivity of polymer. And this is Evolute study, a 5-year clinical outcome, compare synergy stent with promise element, the third generation drug-eluting stent with the second generation, and you can see the less TLR, less string thrombosis, less MACE. Parallel with this, we have polymer-free metallic stents. Once the drug is eluted, a BMS is left behind, and potential advantages was more uniform drug delivery, no adverse polymerase reaction, potential more rapid healing, and shorter mandatory duration of dual antiplatelet therapy. Parallel with us, we have next generation, fourth generation resorbable magnesium scaffold. This design reduces long-term complications associated with permanent stents, but the data until now with magnesium scaffold face challenges and leading to limited use. We move to imaging diagnosis and advancement. Not going. Intravascular ultrasound imaging guided angioplasty was compared to this study in New England Journal of Medicine with angiography guided complex PCI, and among patients with complex coronary artery lesions, IVUS guided PCI led to lower risk and the composite of death, TV target vessel related MI, and target lesion revascularization. We can assess with these tools the assessment of lesion morphology. For example, features of vulnerable plaque. You can see the thin cap fibroatheroma, inflammation with infiltration of macrophages, intraplaque neovessel, and also you can estimate the mechanism of acute coronary thrombosis. You can see the plaque rupture, the plaque erosion, and the calcifying noodle. Angiography illustrates the severe calcification of the left main coronary artery disease. You can see a multimodality invasive assessment of coronary plaque classification. The importance of physiological assessment of coronary stenosis with FFR and the instantaneous wave-free ratio to IFR as the standard of care of assessing the clinical significance of coronary stenosis and the need for revascularization. Recently, non-invasive coronary CT angiography has been recommended, as you can see in the slide, in the left part, with lesions with calcium in proximal LAD and left main, and cross-sectional estimation of the lesion. And also, the FFR derived from CT angiography, the CT-FFR, have been shown to have high diagnosis accuracy with invasive FFR as a reference. Emergency techniques. Today, interventional cardiology can expand it in all the types of lesion in coronary trees and all the kind of patients. We can deal with left main disease, with small vessels with drug-coated balloon, with calcified lesions, with high bleeding risk patients, and with bifurcation stents. We briefly refer to left main coronary artery calcified lesions. The standards of PCI for unprotected left main coronary artery disease are pre-procedural imaging and functional assessment, procedural planning based on anatomical characteristics, new generation drug-eluting stent with thin struts, POT with proximal optimization with or without kissing balloon, and post-procedural imaging. The cutoff value as you can see for the LITRO study, prospective study, validated IVUS-derived MLA, cut-off of 6 millimeters square for deferral of revascularization in patients with unprotected left main coronary artery disease, and FFR was 0.8 and IFR 0.89. With this kind of measures, you can defer revascularization procedure. Current guidelines provide class 1 recommendation for PCI as an alternative to CABG in left main coronary artery disease and low to intermediate anatomical complexity. In relation to heavily calcified coronary stenosis, is the main obstacle for interventional cardiology today. The prevalence of moderate to severe calcification, according to studies with core laboratory angiography assessment, is between 20 and 30%. You can see in the slides how you can deal with this problem, heavily calcified coronary stenosis. At the beginning, we have to imagine, to assess them with imaging, or CT angiography, IVUS, OCT, or conventional coronary angiogram. And after that, I have to select the tool in relation to lesion. If there is deep calcium, undilatable lesions, you can choose between rotational atherectomy, orbital atherectomy, intravascular lithotripsy, high-pressure balloon, and cutting balloon. After that, post-PCI assessment, again with IVUS, OCT, and enhanced angioimage. This is the new rotational atherectomy. The name is Rota Pro. Rotational atherectomy system is distinguished from the rotablator by digital console and the elimination of the foot bedroll. Indications for rotational atherectomy was calcified lesions, long and diffuse calcification, ostial lesions, undilatable lesions, unable to cross with balloon or cutting balloon, calcified bifurcation. Here we can see the IVL intravascular lithotripsy balloon catheter system, includes miniaturized lithotripters that are integrated into a semi-compliant balloon filled with a mixture of contrast saline. Clinical experience with IVL has shown that IVL may induce calcium fracture, also have been used in stent restenosis or other expanded stents implanted in severe calcified lesions. Here is an example of balloon uncrossable chronic total occlusion lesion treated with rotational atherectomy and intravascular lithotripsy. We can combine these two modalities, and you can see the fracture post-IVL and the good apposition of post-stent after that. Recently, we use orbital atherectomy. This machine reduces intimal calcium and fracture medial calcium, and this fraction of medial calcium is easy to optimal stent for delivery and expansion. You can also deal with this difficult bifurcation lesions. In these slides, you can see the efficacy of provisional technique in a modified stent platform, allowing the achievement of a good result in a patient with a complex bifurcation lesion. And on the right of the slide, you can see the three-dimensional OCT reconstruction of the final result achieved. I have to emphasize in this trial, which announced in the ACC Congress 2 months ago, and simultaneously published in Lancet 2024, this trial suggests that PCI of focal no FFR positive plaques, no functional significant lesions that are angiographically above 50% and have evidence of vulnerability on intravascular imaging. So PCI preventing PCI in this kind of lesion is superior to optimal medical therapy for clinical outcomes at 2 years among patients with predominant chronic coronary artery disease. The majority of this benefit was driven by a reduction in subsequent revascularization, include TLR. This trial stimulates a lot of discussion in cardiology community about the prevention of stenting, the prevent stenting strategy. The future belongs to personalized medicine with genomic and proteomic therapies on individual patients, and robotics and artificial intelligence, regenerative medicine. With this, all this evolution, today, PCI is the most frequent intervention performed in medicine. Thank you very much.
Thank you, Dr. Kanakakis, for this very excellent presentation. We are out of time, and so we have to move to the next presentation, which is a recording, I think. It's coming from UK, Artificial Intelligence and Coronary Artery Disease. Will be given by Matt Kelly. Matt Kelly is, I think, head of IP and clinical strategy, Caristo Diagnostics UK.
Diagnosis and management of coronary artery disease, specifically looking at stenosis, coronary artery calcium score, high-risk plaque features, and coronary inflammation. The effective delivery of these imaging tools can be greatly enhanced with the application of artificial intelligence to not only simplify procedures, but also save analysis time, improve quantification, and reveal new information. Starting with the evaluation of stenosis, you'll be familiar with the fractional flow reserve. FFR estimates the functional significance of a coronary obstruction, and is traditionally measured by passing a pressure wire through the stenosis and looking at the change in pressure before and after the obstruction. There are a number of virtual FFR approaches on the market, and most rely on computational fluid dynamics to simulate the impact of changes in anatomy and diameter of the vessel on blood flow. However, more recently, deep learning has been applied to directly estimate the FFR from the vessel, and has shown good agreement with the ground truth invasive measures. Compared to wire-based approaches, these virtual FFR methods are less invasive, shorten the procedure time, and significantly reduce medical costs. Of course, clinically, focusing purely on stenosis misses the majority of heart attacks. Most heart attacks occur in patients with low or minimal stenosis. And this is also supported by a recent study that was presented last year at the AHA late breaker session, which showed that twice as many cardiac events and fatal cardiac events occur or no obstructive disease. Moving on from stenosis and obstructive disease, the calcium score is a common method for risk stratifying patients. The Agatston score is the most widely used coronary artery calcium score in clinical practice, and it is recommended in guidelines as a risk stratification tool for patients with or suspected of having coronary artery disease. This score uses a standardized CT acquisition and calculation protocol, which is great because it means results are consistent across centers and patients, which is very important for generating a risk score and assessing this score's impact on prognosis. However, it's quite a manual process, and it can be time-consuming and tedious for a clinician to perform. There are a number of AI-based methods that automate this process. For example, the image on the right shows a product from GE Healthcare, which provides automated calcium score. This application of AI can help with the identification of coronary artery territories, segment the calcifications within those territories, and calculate per territory scores. And these commercially available solutions have reported high accuracy against manual analysis. And calcium score, as we mentioned, is a prognostic score. It does, people with a higher calcium score do have poorer outcomes. However, its use is complicated by the impact of treatment. So statin therapy shows this converse increase in calcium score due to the healing or cooling down of plaques, moving from a non-calcified to a calcified state with the introduction of statins and the associated reduction in risk. And this confounding impact of treatment on calcium score can make its use clinically complicated. Moving on from calcified plaques is a focus on high-risk plaque features, which are more tightly coupled to plaque ruptures and cardiac events. These include positive remodeling, low attenuation plaques, napkin ring sign, and spotty calcification. Focusing in on lipid-rich plaques, which are thought to be responsible for most cases of acute coronary syndrome. However, the subtle appearance of these low-density, low-attenuation, non-calcified plaques can lead to low interoperator agreement and significant variation in their detection and measurement. Artificial intelligence has shown clear value here, with convolutional neural networks being trained and used to not only improve precision, but also improve performance of accuracy against a gold standard such as near-infrared spectroscopy, which can be used to make more detailed measures of lipid-rich plaques. These softwares not only improve detection, but also show good agreement in terms of quantitative measures of plaque volume, plaque diameter, vessel dimension. However, any AI-based method which is trained on large numbers of data sets is very sensitive to the data that was used to train it. And we know that variations in acquisition parameters for your coronary CT angiography can have a significant impact on the tissue intensities in that image.
And now I would like to call Mr. Sotirios Prapas to present one of the leading figures of cardiosurgery of the 90s.
Sorry for this delay, but we are not responsible for that. During the time in which the moderations are going down and the technicians will change the plaques, we will present a video to save time of a protagonist of the 90s in Greece, is Dr. Alkis Michalis, who was pioneer on using both mammaries since 1986. We would like to honor him with the other 7 wise men. After that, the wise men will be here. Give us just a few minutes.
Now we please call the President of the Hellenic Society of Cardiothoracic Surgery, Dr. Kosmas Iliadis, to hand the prize.
You can imagine the honor that I'm feeling right now. I would like to thank Sotiris Prapas, a pioneering surgeon, and Kosmas Iliadis, our president, the president of our society, for handing me this award. I don't know if they realized that they are handing the award to a farmer and not to a cardiac surgeon, since after 2015 I'm retired. I want to mention two things that I feel are very important in understanding why Greece should be considered one of the countries where myocardial revascularization procedures took place much more in advance than in other countries around the world. Until at the beginning of '90, most of the Greek patients had to travel abroad, mainly in United States and United Kingdom, to have the graft operation that Favaloro introduced almost 20 years ago. When George Green introduced and published his first results using the internal mammary arteries, I decided to visit the Oxner Clinic, Montreal Heart Institute, and Green Lane Hospital in New Zealand, where I learned the technique, but most importantly, I learned the concept of how a complete revascularization should be. That meant that you have to use the best graft, certainly the internal mammary arteries, and second, aim to correct the lesion to the most important arteries that they were diseased and they were threatening the largest portion of the myocardial mass. That means that with the two internal mammary arteries, you could complete a complete revascularization. In this way, the population of about 8,000 patients that my team and myself performed from 1985 up to 2015 experienced improvement in their survival. The curve was higher than the curve of the mean population, and also experienced a minimization of complications, rehospitalization. That means that we offer to these patients, by using the one or two internal mammary arteries, quantity and quality of life. In this journey, I was not alone, and it is the last comment that I will make. I have to name my colleagues that together, the same staff completed this journey. Surgeons were Mazen Houri, Makis Azariadis, Panagiotis Kalogris, Nikos Michalopoulos, and Sterios Dimitriou. The anesthesiologists were Christina Antsaka, Thanasis Nikolaidis, Martha Deligiani, Marina Balanika, and Anna Smirli. And finally, our chief pump technician, a close friend of mine, was Thanasis Sakorafas. The only thing I have to tell about this person is that the surgeon felt always behind his back another wise, experienced cardiac surgeon handling the pump. To these people, with these people, I would like to share this award, the pride that I'm feeling right now, and the deepest of my emotions. Thank you.
And now allow me to announce the names of the moderators of the second session, the theme being the third millennium, critical evaluation and progresses in coronary surgery. Dimitrios Angouras, Professor Cardiac Surgery, National and Kapodistrian University of Athens, Director, University Cardiac Surgery Clinic, Attiko University General Hospital, Athens. Panagiotis Dedeilias, Cardiac Surgeon, Director, Department of Cardiovascular and Thoracic Surgery, General Hospital Evangelismos, Athens. Dimitrios Dougenis, former Professor of Cardiac Surgery, University of Athens. Dimitrios Iliopoulos, Professor of Cardiac Surgery, National and Kapodistrian University of Athens, Director, 4th Cardiac Surgery Department, Υγεία Hospital, Athens. Theodoros Kofidis, Cardiac Surgeon, Director, 1st Cardiac Surgery Clinic, Υγεία Hospital, Athens. George Stavridis, Director, 3rd Department of Acquired Cardiac Disease, Thoracic Surgery and Hybrid Technique Unit, Cardiac Surgery Sector, Heart and Lung and Mechanical Support Transplant Unit, Onassis Cardiac Surgery Center, Athens. Ioannis Klorogiannis, Cardiac Surgeon, Director, Cardiac Surgery Clinic, Euroclinic, Athens. And now we call Stella Papandreopoulou.
Good evening. Thank you for your patience and for being with us tonight. So my work here is to honor the 7 wise men of coronary heart surgery. So, to cut a long story short, I will start with the videos and the presentation of Dr. Federico Benetti from Argentina.
Dr. Federico Benetti is celebrated for his pioneering contributions to cardiovascular surgery, marked by dedication, skill, and innovation. His academic journey began in Rosario, Santa Fe, Argentina, where he completed his primary, secondary, and undergraduate education, graduating from the National University of Rosario in 1972, with a focus on cardiovascular surgery. Dr. Benetti underwent rigorous general surgery training at the Spanish Hospital and the Ferroviario Hospital in Rosario under Dr. Pablo Benetti Aprosio, where he developed his surgical skills and gained emergency care experience. He further specialized in cardiac surgery in Brazil at the Hospital das Clínicas de la Facultad de Medicina de Sao Paulo under Professor Dr. Paulo de Almeida, Toledo, acquiring expertise in complex cardiac procedures. Dr. Benetti's commitment to continuous learning is evident in his participation in specialized cardiac surgery courses and residencies, along with pursuing recertifications and titles. His innovative spirit led to the development of the bubble oxygenator in Sao Paulo in 1974, the Phase 3 duramater valve and the test machine for artificial valves in Rosario in 1977, Dr. Benetti holds 31 U.S. patents for off-pump surgery technologies and 2 U.S. patents for surgical methods, including the mid-cub xiphoid approach, and co-invented the CyberHeart. He has served in leadership roles such as Chief Cardiac Surgeon at the Institute of Cardiology in Rosario, President of the Benetti Foundation in Argentina, and Director Emeritus of the Minimally Invasive Cardiac Institute at the Miami Heart Institute. Dr. Benetti's dedication to education and teaching has influenced countless surgeons through courses and training programs in over 45 countries, focusing on minimally invasive cardiac surgery techniques. His work has been recognized with numerous awards, including the Corazón de Plata Award in 1979 and the Participation Award from the Sencor Maison de Santé in 2013, highlighting his significant impact on cardiac care worldwide. Dr. Federico Benetti's legacy in cardiovascular surgery is characterized by his groundbreaking research, innovative techniques, and dedication to improving patient care, inspiring future generations in the field.
Ναι. I call Dr. Stratis Padakos to honor Dr. Benetti.
Thank you.
Thank you, Steve.
If you want to?
No, okay.
Okay, so the next one is Antonio Maria Calafiore, who is cooperating with us at the Henri Dunant Hospital Center. And together we are doing research on coronary artery disease.
Antonio Maria Calafiore was born in Syracuse, Italy, on September 14, 1947, and graduated from the University of Catania on July 12, 1971. He completed postgraduate boards in general surgery at the University of Turin in 1977 and in cardiac surgery at the University of Bologna in 1978. Professor Calafiore held various academic appointments, including assistant professor in cardiac surgery at the University of Torino and the University of Chieti, and full professor in cardiac surgery at the University of Chieti and the University of Torino. He served as director of the School of Specialization in Cardiac Surgery and Cardiovascular Perfusion at the University of Chieti and later at the University of Catania. His hospital appointments include director of the Division of Cardiac Surgery at the University of Chieti, the University of Torino, and the University of Catania, as well as various roles at the Prince Sultan Cardiac Center in Riyadh, Saudi Arabia. Professor Calafiore also held positions as visiting professor at Henri Dunant Hospital in Athens, Greece, and as a consultant at several hospitals in Italy. His training periods include time at the Division of Cardiac Surgery at Hospital Lennec in Paris and Clinique de la Résidence du Parc in Marseille. Professor Calafiore has been a member of several prestigious societies, including the Italian Society of Cardiovascular Surgery and the American Association of Thoracic Surgery. He has published 335 papers as reported by PubMed as of April 2024, and has served as an associate editor and editorial board member for numerous journals in the field of cardiac surgery. His contributions to the field are further highlighted by his leadership roles in various surgical societies and his extensive involvement in editorial activities for major medical journals. Professor Calafiore is recognized for his work in myocardial protection and the use of all arterial conduits in cardiac surgery. His research has covered various aspects of cardiac surgery, contributing to the broader academic and medical community's understanding of complex surgical procedures and patient care. His leadership roles have allowed him to influence the direction and standards of cardiac surgery both in Italy and internationally. These achievements underscore Professor Calafiore's significant impact on the field of cardiothoracic surgery through both his clinical innovations and his contributions to medical education and research.
I call Azari Yaqub from Malaysia. He is with us today, and he will honor Antonio Calafiore.
Thank you, Professor. And we move on to one of the greatest innovators in cardiac surgery, Dr. Valavanur Subramanian.
A. Subramanian is a prominent figure in cardiothoracic surgery, serving as the chairman of the Department of Cardiothoracic Surgery at Lenox Hill Hospital in Manhattan. His career achievements include being consistently recognized among New York City's top cardiothoracic surgeons by New York Magazine for 15 years. Dr. Subramanian is renowned for his pioneering work in minimally invasive and robotic cardiac surgery, significantly advancing treatment in methodologies to the field. He has contributed extensively to global medical conferences, serving as a speaker and visiting professor at over 150 events worldwide, enriching discussions on cardiothoracic surgery. His academic contributions include over 150 abstracts, articles, and book chapters, enhancing the academic literature and understanding of cardiothoracic surgery. Dr. Subramanian founded the International Society for Minimally Invasive Cardiothoracic Surgery and served as past president of the Lillehei Surgical Society, influencing the direction of cardiothoracic surgery. His educational background includes studies at Christian College and Stanley Medical College, University of Madras, followed by further training in the United States, including roles at the University of Minnesota. Dr. Subramanian has developed groundbreaking medical technologies such as the first disposable practical clinical membrane oxygenator. Beyond his professional achievements, Dr. Subramanian is dedicated to philanthropy, supporting organizations like the Queen's Child Guidance Center and Children's Hope India, alongside his wife Myrna. His numerous accolades include the L.H. Pedersen Memorial Award, the Dedication of Service Award from New York Hospital, Cornell Medical Center, and the Award for Outstanding Achievements in Surgery from the Association of Indians in America. Dr. Valavanur A. Subramanian's legacy in cardiothoracic surgery is defined by his commitment to excellence, innovation, and compassionate patient care, leaving a lasting impact on the field and inspiring future medical professionals.
I call Mrs. Fotini Danu, Director of Anesthesiology in Heredina Hospital, to honor Dr. Subramanian.
Okay, and now next wise surgeon from my favorite country, Japan, Dr. Hisayoshi Suma.
Dr. Hisayoshi Suma is a renowned cardiovascular surgeon from Hyogo, Japan, celebrated for his significant contributions to medical science and patient care. Born on March 1, 1950, Dr. Suma's journey in medicine began with a deep-rooted passion for making a difference in cardiovascular surgery. He received his medical education at Osaka Medical College, where he graduated in 1974, establishing a solid foundation in medical knowledge and skills. Dr. Suma furthered his education by obtaining a PhD in 1988, demonstrating his commitment to academic excellence and research in cardiovascular medicine. His postgraduate training included cardiovascular surgery at Juntendo University in Tokyo under Professor Akio Suzuki and at LDS Hospital in Salt Lake City, USA under Professor Russell Nelson. Dr. Suma's professional career is marked by roles such as a staff surgeon at Osaka Medical College and directorships at MedDoc Healthcare Clinic and Suma Heart Clinic, showcasing his leadership and expertise. He has been honored with numerous awards, including the Lifetime Achievement Award from the International Coronary Congress in 2022 and the Honorary Award from the Japanese College of Cardiology in 2010. Dr. Suma's research contributions include the development of the ventriculoplasty procedure and the use of the gastroepiploic artery graft, which have significantly advanced cardiac care and patient outcomes. As a clinical professor of cardiovascular surgery at Kagawa University, Dr. Suma is committed to educating the next generation of medical professionals. Dr. Hisayoshi Suma's legacy is defined by his dedication to innovation, leadership, and patient care in cardiovascular surgery, influencing the medical community worldwide.
I call Professor of Cardiology in the University of Athens, Dimitrios Toussoulis, to honor Dr. Suma.
Thank you. And now we move on to, how can I say, if the mustache was a trademark, then definitely Dr. Thomas Salerno would be the one owning it. So we will watch a video for Dr. Thomas Salerno from Brazil.
Dr. Thomas A. Salerno was born in Caxias, Sul de Minas Gerais, Brazil, into a modest family, marking the beginning of his journey to becoming a distinguished figure in cardiothoracic surgery. His academic journey started in Sao Paulo, Brazil, where he balanced work during the day with school in the evening. This dedication led to a scholarship from the Leopold Shep Foundation in New York, enabling him to study at McGill University, where he earned his MD degree in 1971. Dr. Salerno's postgraduate training included general surgery and cardiovascular and thoracic surgery at Royal Victoria Hospital in Montreal. He has held academic leadership roles at Queen's University, McGill University, University of Toronto, and State University of New York in Buffalo, before becoming the chairman of cardiothoracic surgery at the University of Miami, Florida, USA. Throughout his career, Dr. Salerno has significantly contributed to cardiothoracic surgery through research, innovative surgical techniques, and extensive publications, including books, book chapters, and peer-reviewed articles. He has also served on the editorial boards of several scientific journals. His professional achievements have been recognized with numerous awards, such as the Zeppa Achievement Award, Best Doctors in America Award, and Laurea Honoris Causa from Italy and Argentina. He has received proclamations and awards from various international entities, including the Mayor of Miami, Dade, the Premio Montevergine from Napoli, Italy, and the international honorary membership of the National Academy of Medicine. Dr. Salerno has been instrumental in institutional development and leadership, serving on various committees and task forces at both the medical school and university levels, demonstrating his commitment to institutional improvement and influence. His dedication to education is evident in his role in training over 120 cardiac surgeons and promoting innovative techniques in cardiac surgery. As the editor-in-chief of the Journal of Cardiac Surgery and chair of the Faculty Senate at the University of Miami, Dr. Salerno continues to inspire future generations of medical professionals and shape the future of cardiothoracic surgery with his commitment to excellence and innovation.
I call Dimitrios Ankouras, Professor of Cardiac Surgery at the University of Athens, to honor Professor Salerno.
No, he wants to shave the mustache when he goes back home. No. So we move on to Dr. Naresh Trehan from India.
Dr. Naresh Trehan is a prominent figure in cardiovascular surgery in India. He was born on August 12, 1946 in Karachi, India, now Pakistan, into a family of medical professionals with both parents being doctors. Despite his parents' initial reluctance, Dr. Trehan pursued medicine, inspired by the profound impact it has on society. His early education at Modern School in New Delhi, where he excelled in sports and aero modeling, instilled in him a competitive spirit and resilience. Dr. Trehan completed his undergraduate studies at King George's Medical College in Lucknow before moving to the United States for further training. At Thomas Jefferson University in Philadelphia, he specialized in cardiac surgery under the mentorship of Dr. Frank Spencer. After nearly 2 decades in the US, working at institutions like Bellevue Hospital in New York, Dr. Trehan returned to India in 1988 to serve his homeland. He founded the Escort Heart Institute and the Research Center with H.P. Nanda, revolutionizing cardiac care in India through advanced treatment, training, and research. Dr. Trehan also established Medanta, the Medicity, one of India's largest multi-super specialty institutes, modeled after top medical institutions in the US. Throughout his career, Dr. Trehan has received numerous awards. His journey reflects the impact of determination, innovation, and service in transforming healthcare in India.
Three principles. One is that you must exercise. Then the second is diet. Now the diet has to be balanced. The third thing most important today is stress. How to neutralize stress. Yoga is the best form of de-stressing, and the pranayama of yoga is your best defense. So if you practice these three things on a daily basis, that's the best you can do for yourself.
Great. Please, I would ask Panagiotis Delias, the incoming president of our society, the Hellenic Cardiothoracic Surgery Society, to honor Professor Trehan.
And now we move on to the last wise man, Dr. Gianni Angelini from Tuscany.
I'm Italian. I was born in Tuscany, in this old, beautiful place called Siena, which is an old medieval town. As a matter of fact, when I was in my teens, I wanted to be an engineer. And in fact, my dream was nothing to do with medicine. I wanted to fly aeroplane, and in particular Concorde. So as I was doing my engineering degree, it just happened and I had a small injury to my left eyes, which was promptly resolved. So as you can appreciate, my career as an airline pilot was over even before I ever started. So what was the next option? In my country, any parents want you to be an engineer, and well, if you have to go for the second best, why not to trying to be a doctor, since this usually doesn't require to be too clever. What I want to demonstrate to you this afternoon is that heart surgery is nothing but applied engineering.
Professor Gianni D. Angelini is recognized for his transformative contributions to cardiac surgery and research, with a career spanning over 3 decades. In 1992, he was appointed as the British Heart Foundation Chair of Cardiac Surgery at Bristol University, where he significantly improved the unit amidst the national scandal, achieving the best results in the UK within 5 years. He founded the Bristol Heart Institute in 1996, which has become an international center for cardiac research and treatment, hosting over 300 scientists and clinicians and securing over £90 million in funding. Professor Angelini's international impact includes performing the first open heart procedure in the Caribbean in 1993 and restructuring the cardiac surgery service at the Prince of Wales Hospital in Hong Kong in 1994. He established the first cardiac surgery databases in the UK in 1996, contributing to the development of the UK National Cardiac Surgery Database. In 2002, he pioneered coronary artery bypass surgery on the beating heart, a significant achievement published in The Lancet. Throughout his career, Professor Angelini has been dedicated to fostering talent in cardiac surgery, leading to accolades such as the 2005 Hospital Doctor Surgery Team of the Year Award. In 2008, he led the bid for the first NIHR Biomedical Research Unit in cardiovascular science, further establishing his leadership in cardiac research. From 2010 to 2016, He served as the British Heart Foundation Professor of Cardiothoracic Surgery and Head of Cardiac Surgery at the ANHLI Hammersmith Hospital campus, Imperial College London, transforming it into a center of clinical and research excellence. Professor G.D. Angelini's career is marked by his relentless pursuit of excellence and leadership in cardiac surgery and research, making a lasting impact on the field and inspiring future generations.
Professor Angelini, now from the past to the new generation. Nicoleta Stanitsa, a surgeon in training in Evangelismos, is going to honor Professor Angelini. Now the moderator will give the opportunity to some surgeons to make questions with short answers from the 7 wise men.
Okay, well, thank you very much. I would like to ask first Dr. Vasiliki Vicky Androutsopoulou to ask a question to Professor Benetti. Dr. Androutsopoulou is a consultant cardiac surgeon at the University Department of Cardiothoracic Surgery at the University of Thrace. Dr. Androutsopoulou, please.
I feel privileged that Dr. Prapas gave me the opportunity to address this panel of eminent pioneers in cardiac surgery. My question is addressed to Dr. Benetti. Dr. Benetti, which of the following parameters do you consider as the factor that made you one of the pioneers of the off-pump technique? The philosophy, the cost efficiency, or others? Thank you.
Thank you. Thank you for the question. I don't know if it works. Okay. Yeah, thank you for the question. You know, I started doing beating heart in 1978 occasionally, so I didn't know that this operation was done before. I have a patient ready to put on pump, and I don't know why. I decided that I occlude the LAD artery, and I put a graft on it, and then I continued with my second patient. So my anesthesiologist came and said to me, I estimate the first patient, he doesn't look like I have a heart operation. So in this year, the second patient was a woman that I did 2 grafts, and the third was a friend of mine that had a stroke. So I started thinking that it was a good option, and then I moved and I opened another center in the state of Buenos Aires, where I have a lot of old patients in bad conditions, and in this center they don't have so much money, so I started doing more and more off-pump because we save the money of the oxygenator. In these years, also Ennio Buffalo started doing in Brazil, so we both together practically developed the technique for these years, and in this center in the peripheral of Buenos Aires, I started doing a lot of kind of operation, like treating acute MI infarction, using the mammary, and developing all of the technique. And up to 1990, we achieved 700 patients of pump. So in that moment, I was totally convinced that was the way to go. So most of my patients, I did in that way, up to today. So I don't know if I can answer your question that way, it's okay.
Now, I would like to ask Dr. Baikousis, who is a very keen...
One moment, please.
Thank you. Thank you very much. I would like to ask Dr. Baikousis, who is a very keen cardiac surgeon at Hippocrates Hospital of Athens, to address a question to Professor Calafiore, please. Make it in Italy if you want to.
Thank you for the microphone. I have a question for Professor Calafiore. You worked on cardioplegia and published the protocol for warm blood cardioplegia that is still...
We cannot hear, sorry. Please. Both perhaps.
One moment.
Ρενικό, πάρε αυτό εδώ.
Professor Calafiore, wow! I have a question for you. You worked on cardioplegia and published a protocol for warm blood cardioplegia that is still used today. Why did you work on OPCAB?
The problem was related to what happened at the time. We must consider that the problem of myocardial protection was very important, anyway, was always important. When I knew that Tom Salerno was working and published a beautiful, great paper on warm cardioplegia, I had already this idea in mind, and I found that was the best way to protect the myocardium. But remember that at the time, the cardiopulmonary bypass was not as safe as it is now. So limiting the cardiopulmonary bypass or avoiding it could be good, especially in some subgroup of patients. Remember that at that time, we are talking about end of 80s or 90s. The patient that arrived to the cardiac surgeon were very good patient with a few 2-3 vessel disease with the beautiful vessels. So this was really facilitating the concept of the beating heart. And this is the reason that pushed me to avoid the cardiopulmonary bypass in the coronary patients that were a little bit more risky than the others because of the comorbidities that are typical of this patient. And so I was playing in two different tables. One on myocardial protection when I had to use the pump, and when on the beating heart to reduce the comorbidities related to the pump or that the time was not safe. Thank you.
Dr. Suma, it's an honor to have you with us today. Most of us are very familiar with double mammaries and radial artery, but not so much with the gastrocleploic artery. Do you think that there is still a role for this graft in modern surgical revascularization?
Well, thank you. May I sing? Wise man said. Yes. Gastrocleploic artery is still viable and variable conduit for coronary artery bypass grafting. In fact, in the recent Japanese national study have shown that annually the gastrocleploic artery graft was used in 800 to 900 cases in about 11 to 12,000 cases, isolated coronary artery bypass cases. So it's a size of number of cases. So in the Japanese heart surgeons still believe the gastrocleploic artery works. And I started out this operation in 36 years old. It was 38 years ago. And since then, I performed more than 1,000 cases of using gastric graft. And for the long-term survival rate and the long-term patency rate is quite high. I published in Circulation and JTCS. And among those patients who survived more than 20 years, some of them come to the hospital because of chest pain, but all of them are because of sufficient vein stenosis or native coronary artery stenosis. And the gastric artery and the mammary artery are widely patent. So I do believe the gastric artery is very, very important conduit in the CABG. Sing more?
Should we proceed? It's my great honor to present Dr. Argyriou, who is one of the most profound cardiac surgeons in Athens. And he has a very particular question for Dr. Subramaniam. In your opinion, what the role?
Okay.
Dimitris,
no. In your opinion, what role do companies play in the development of cardiac surgery?
Unfortunately, the role is very limited today. And as we know, when we started MedCab, the greatest contribution was doing a mechanical stabilizer. CTS was a company which was Benetti and myself were part of it. And the mechanical stabilizer came into use, and then it made OpCab easier. There's been no structural, training in the residency training program still. And the peer-to-peer training went away, and there's no guidelines in the societies. There's not been a procedural benchmarking and a real powered data collection to prove the evidence that is at least non-inferior. Having said that, I think there's a great future, as you're listening to the young Giancarlo was talking about, the robotic mid-cab, totally endoscopic has a tremendous role. But you have to have a good training center. And the industry has to play a lot of part because they have not really put a lot of money in developing further than the stabilizer, further than the robot. I will tell you that the money right now is going to the interventional cardiology. I'm in the interventional cardiology space in a valve transcatheter company. I can tell you if I have a good concept, I tell them if I have a surgical concept, they're asking me that, do you have a catheter prototype? The money is out there, it's billions of dollars. The Edwards Life Science, for example, spent about $260 million in the surgical arena, cardiac surgery. So I think we need a young inventors to come up with a completely crazy idea, which what I did. When I did it, I did not have any literature search, just thought it would be very good. Just like the spur of the moment, I had one sick patient, not knowing Benetti at that time. So you need young inventors in cardiac surgery who can not only contribute to cardiac surgery, but also contribute to a transcatheter, because our brains and our knowledge is very important for the transcatheter. I hope I answered your question well.
Professor Salerno, thank you for being with us tonight in this outstanding meeting. We are very proud being with you. I'm Dr. Klorogiannis, cardiac surgeon in Athens, and I would like to ask a prominent cardiac surgeon and an excellent colleague in Henry Dinan Hospital, Dr. Protogeros, to ask his question.
Who is it that has the microphone?
Thank you, Dr. Florianis. Great honor to be here tonight. I'd like to ask Dr. Salerno. You were the surgeon that promoted the beating heart internationally. Now that the enthusiasm has waned somewhat recently, do you still have the same attitude towards OCAP?
Regarding the beating heart surgery, I spent my most part of my life studying myocardial protection or cardioplegia, until I began to realize no matter what kind of cardioplegia that you use, published by Angelini, that the heart still suffers. So I developed technology and technique to do all the procedures that include mitral, aortic, double, arch aneurysm, Bentall procedure with the beating heart. And the reason being that it will avoid ischemia altogether, and particularly in the heart that is poor ventricular function, high risks. Regarding off-pump, first of all, the indication for off-pump is coronary artery disease. Everybody who has coronary artery disease should have an off-pump, in my opinion. My enthusiasm for coronary artery surgery remains. It's obviously one of the most important procedures we do in the US, about 500,000 a year. I shared with some of my colleagues the idea, Dr. Pushka, that this should become a subspecialization from the work you heard them, Gianluca presenting here, because very few surgeons can do that. My final comment is, why is it that off-pump has not gained popularity? Only about 10% in the US use off-pump. And the reason is, I've trained about 130 cardiac surgeons, and they never put the patient on pump with me. When they graduated, they're all enthusiastic about, we're going to do off-pump, off-pump. They go to any center, and they say, here, we use the heart-lung machine, cardioplegia, the sutures, so within 6 months, it's all over. But my enthusiasm remains.
The next question will be addressed to Dr. Trehan from India by Dr. Philias, cardiac surgeon from the Eric Tinan Hospital in Athens. Dr. Philias.
Good evening. I would like to thank Dr. Prapas for all this organization, and I feel really honored to be here with you today. I can say that as a almost young cardiac surgeon, I feel that there is a battle not between us, off-pump, on-pump, minimal, maximal, but from interventional cardiology to cardiac surgery. So I think that the only real weapon we have to beat this battle is good long-term results. So do you feel any concern that all these very nice off-pump, complicated conduits maybe compromise the good long-term result that we have when we do a simple mammary to one vessel?
So it's true that off-pump surgery is a little more challenging than on a still heart. So if people who have been trained at centers and do have the opportunity to practice their skill in wherever they go. So like I've been back in India since '88. We started early 1995, we started beating heart surgery, the mid-cabs and the last operation. And over 80 surgeons have been trained in our program since then. We do on an average 3,000 CABGs a year, and 98% are done off pump. So today, if you ask my trainees to do it on pump, they find it much more awkward than to do it on beating heart. And we have done many studies, Dr. Paskas has been part of it also, that there was a consensus report put out by the International Society of Minimal Invasive Cardiac Surgery. What it showed was that if you take a cohort of patients who are elective, who have straightforward coronary artery disease, there is no divergence between on-pump and off-pump. On the other hand, if the ones with comorbidities, especially with uncontrolled diabetes, renal complications, liver, all these people who have comorbidities, there is a divergence in the outcomes, immediate and long-term, in patients who were done off-pump and the ones who, as opposed to on-pump. So there is a clear, definite advantage of doing it off-pump if you are equally comfortable doing it in both ways. So if your skill sets do not permit you to do beating heart because you've not had the right training, I think you should not attempt it. That is true. And that is why some of the larger studies where multiple centers have been used, you can see the differential between the results in different centers. So I think that pure patients, people who are practicing and committed to it have produced great results. There's no question about it. As far as popularizing it in India, we do 160,000, close to 160,000 CABGs a year in India. And 80% are done off pump in all over India. So there has been a huge adoption, and it gives two advantages. Like I told you, that we do have a population which comes late, which comes with renal dysfunction, which comes with liver compromise, and uncontrolled diabetes. So on these patients, there is an advantage, that is one. The other is you eliminate the heart-lung machine and the consumables, you save at least 25% of the cost of doing the operation because everything is imported that is consumed from overseas or from the US mainly, and that adds to a huge cost. So it has helped to make it accessible for more and more people who otherwise may not have been able to afford it. So there are multiple benefits in a country like India, and the surgical skills of our trainees have actually permitted them to do 80%, 90, 95, 98% of pump in different centers. Thank you.
Thank you. And now I would like to ask Dr. Alexopoulos, Professor of Cardiology in Athens, to address a question to Professor Angelini, please.
First paper on the hybrid precision, who is most reluctant to accept?
Thank you. Well, to start with, an hybrid procedure involves two clinicians. So in terms of pure economy, it costs a lot more. And that is the main problem. And this is whether you are in a national health service system or in a private institution. When we first started this, and we did a whole series, we were doing everything in one go, which obviously reduced timing, admission, cost, and everything. But things have changed because you interventional cardiologists now have got more sophisticated means to do the PCI. So it can't be done, in my view, all in one go, because if we do the surgery and then you do the PCI and place stent and give a lot of nasty drugs, as you have to, the patient will either bleed a lot or actually bleed to death. So it has to be a staged procedure, which in my view should be the surgery followed even 24 hours later by PCI.
There are two technical aspects, however, which I think are making it, or have made it difficult so far. The way we conceived the mini thoracotomy and the way we took down the mammary artery, which is the most important part of the procedure, often resulted in stretching the ribs and even cracking the ribs. The results was that this patient had pain postoperatively and even in the long term. And this is, my opinion, is one of the reasons why the technique never really developed on a big way. I think we've heard today about some of the innovation, and there is no doubt in my mind that if you can take the mammary endoscopically, either with a direct endoscope, or even better, if you got the fortune to have a robot, robotically, it will change the whole pictures. And it will make a procedure really minimally invasive, minimal accept, and acceptable and successful. I truly believe for the cardiac surgeon, the only way ahead is collaborating with the cardiologist, because I'm afraid we are a dying race as cardiac surgeon. And I truly believe that, and not just say because I've reached a stage almost of retirement. So those kind of joint approach are the future. And I'll just conclude it by saying this is already happening on a big way when you think about primary PCI, because you do the procedure and maybe we finish it off 2 or 3 weeks later or a month later. So I truly believe the only way ahead is collaboration and not arguing what is better and what is not so good.
Dear friends, I'm sorry, but the time is limited because of the problems. But I would like to give the opportunity to two persons in training to ask you a question about the future. Everyone will answer, but very shortly, please.
Good evening. As cardiac surgery residents, we are honored to be in the presence of such distinguished professionals, and we would like to thank the organizing committee and especially Mr. Prapas for providing us with this opportunity. We would like to ask what are your future expectations concerning surgical treatment of coronary artery disease, and what is your advice to a young resident who would like to subspecialize in coronary artery surgery? Thank you.
How's the order? Okay. Professor Benetti, we need your answer, please.
The future is fantastic for the cardiac surgery because the cardiac surgeon have the train to learn how to do interventional cardiology. And the actual situation in the world is complicated in the sense of the amount of money that you are spending in health. So there is not any sense to have so much division. So for the future, I believe that the cardiac surgeon will be trained to do most of the procedure. We are today doing acute MI without going to the interventional suite. We go directly from the CT scan to the surgery. So the future, I confirm that is fantastic for the cardiac surgeon.
Professor Calafiore?
The future of cardiac surgery, I sorry, but I disagree with Federico. I think that the future of cardiac surgery is totally different from what I thought, at least in the past. I am glad of the life I lived, because I lived the golden era of the cardiac surgery. But you must be aware that now, because of the, let us say, competition with the cardiologists, we are going to reduce more and more our spaces. My generation, and even after the generation after mine, was exposed to all the possibilities, cardiac complication of myocardial infarction, of everything. So we saw cases that were honestly awful, but we were doing all these cases and we're trying to do the best way to do these complicated cases. Now the new generation, at least the generation of the surgeons I know, the young generation, as soon as they see a complicated case, they say, what they can do, the cardiologist for us, because they don't want to touch complicated patient. Remember, the regulation changed a lot. Now you are controlled, they check your mortality, your morbidity, they can even cut or eliminate your license to practice. So everybody is scared by a world that is changing. How this will finally finish, we don't know. But surely there will not be the cardiac surgery I lived in my life. Thank you.
Thank you, Professor. Professor Subramanian.
I'll be very brief I'll be brief and blunt. Cardiac surgery will decrease, will become the artist colonies, but to survive in the artist colonies as a young residents, you should search out good mentors and a good training program for advanced cardiac surgical techniques like the use of robot and multiple arterial grafting. So I don't think it's going to be just a one set of a training, because competition is getting stiffer. I do believe in the advances in the transcatheter therapy is going to be phenomenal. I'm not saying because I'm involved in that, but I do think that's the progress. Civilization has always changed. The world is going to change. World will change.
Thank you, Professor. Professor Suma.
Well, concerning about the future of the coronary bypass surgery, when look back the history of bypass surgery, when in 1960s, it's evolved by a saphenous vein graft. And on those days, no one think arterial graft going to be a main interest. 20 years later, in the 80s, we are all rushing into the arterial conduit. On those days, no one believed open bypass dominates. And 20 years later, in the year of 2000 now we are talking about open bypass and robotics and the AI, right? So I don't know what's going to come next, but for the training program, it's very difficult. If AI and robot do by themselves bypass surgery, there is no subspecialty at all. But unless man using a robot, this is a very huge subspecialty. So we have to be very, very careful to watching what the way we are moving. That's my feeling.
Thank you, Professor. Professor Salerno, we need your short answer, please.
I don't know how many cardiologists are in the audience, but you know that we stand on shoulders of giants. Who are the giants? Who stand in our shoulders? The cardiologists. So we learn from the past. And I always ask the question, who should have been at the end of that catheter? The guy who could treat the complications. But we were too busy in the operating room. We're not interested in getting out of the operating room. I wrote an article, it's called In My Opinion in CTS.net. And I was pleading on cardiac surgeons to leave the operating room and get involved in the new technology. The cardiologists embraced the technique, the new innovation, technology. One day, there was bare metal stent. Next day, they're not waiting for a 20-year clinical trial. Next day, they abandoned drug-elute stent and bare metal stent and use drug-eluting stent. I have to say one thing that's important. We control our future. When you ask, as a trainee going into cardiac surgery, what is the future? The future is now. I personally wish I was born today. For the excitement, they exist, but you need to embrace everything. If you want to learn about heart surgery, attend the cardiology meeting. That's where you're going to learn what's going to happen to us if we don't change our path.
Thank you, Professor. Professor Trehan?
So, first of all, let me compliment you for choosing the right profession, the right specialty. Challenges are always there, but the future is truly bright because our skills will improve, we will take on more and more challenges to the degree that we have reached a stage. Actually, this is one of the things that at an advantage point for somebody at my stage of the career, that we say we will operate on the inoperable. That means you'll take on those cases, 20% ejection fraction, diffuse disease, which nobody will be willing to touch, but you will be the ones who will save those people by the hundreds. So I think there is, regionally also it makes a difference whether you have diffuse coronary artery disease or you have what are the comorbidities in your region. But I think one lesson that you have heard, and I think that there is no deviance in our view on the fact that off-pump surgery will be more and more suitable for more and more patients. Second, I think if you look at the trials, and I think Dr. David Taggart gave a very good beginning to his talk to say data must be looked at with suspicion. Same cardiologists, when the bare metal stent came in, used to convince the patients that it's only going to be 10% restenosis. Same guys, when the drug-eluting stent came, that had 50%, this one will have only 10%. So this is a sequential claim because nobody knows the long-term data on any of those stents really, or in our own techniques. So the second thing I would say to you is, please document whatever you're doing as you go along. Because being busy in the operating field, operating theater, doesn't always permit you to look at other things. And also, like Dr. Salerno said, that please keep an eye out because you should be doing everything. Why not? Because we know the anatomy better than anybody. The cardiologists used to come into the operating room to look at the aortic valve. We are the ones who taught them what it looks like and what needs to be done. So we should take some of the things back in our hands, which we are fully capable of, or even better than most people are doing. Thank you, and good luck.
Thank you, Professor. And Professor Angelini?
Right, I can reassure you that coronary surgery is not going away. It will be reduced in number, but it will be here for many, many years to come. So I think as a trainees, you have to make a very simple decision. Do you want to be a coronary surgeon or do you want to be a specialized coronary surgeon? And let me give you an analogy. Every heart surgeon who calls himself or herself a heart surgeon must be able to replace a mitral valve. However, when you face with a mitral valve with an anterior leaflet prolapse and you have to put corda, it's not something everybody can do it. And that's why they are specialized in a branch of heart surgery. So what will happen in the future is, since we are talking of thousands and thousands of operations, most of the operation will be done by cardiac surgeons in the old-fashioned way. The demonstration is that the use of arterial graft is less than 10% across the world anyway. So that's not going to change. It's not going to change very quickly. But in my view, what each unit will have to have is the same as for mitral valve surgery. You will have lots of people doing a lot of coronary surgery, but then you'll have some specialized surgeon who, when the unit is presented with a case with all sort of plaque in the aorta, you go and call the off-pump surgeon, but not the one who does an off-pump every year, the one who does it every week. You got a 75, 80-year-old gentleman, I wouldn't worry too much about putting 2 arterial grafts, quite honestly. In fact, if it was me, I wouldn't want 2 arterial grafts. But if you are 50 or 60, you would want the specialized surgeon who can put 3 arterial grafts. So I think this is the future, and it's your choice whether you want to be a cardiac surgeon doing coronary surgery or a specialized cardiac surgeon doing surgery. Obviously, there are a little bit of differences, particularly in terms of training. But it's up to you to choose.
Thank you, Professor.
Now, the other thing which is important is that you've got some great teachers here. Dr. Prapas just presented the new concept of how you can elongate grafts and do sequential everywhere. So these are things that will matter. And if you have the right training, which it seems like you will definitely get, there's no reason to fear the cardiologist.
At the end of this superb symposium, I will thank some persons. First of all, our friends who did a long trip to be here with us. Second, all of you for being here to honor us who organized this symposium. I will thank Sotiria Katsimicha for the organization, my secretaries, but before my team, my secretaries, Papandreopoulou, Dimtsa, B. and Kanelopoulou, Dr. Trikas, who gave us the opportunity to organize this symposium officially, and of course, Alexis Kostalas, the most well-known voice of Greece around the world. Thank you, Alexis. And now I would ask 2 things. First of all, the 7 wise men to stay up, to take a picture for the history of Hellenic cardiothoracic surgery, to say to our grandchildren that happened here in Greece for the first time in the world. Second, at the end of the symposium, anyone who likes to be with us, we can stay at the stairs of the old parliament to take a picture for memory. Thank you very much.
So Dr. Prapas, you will see there are 7 mics have come on together because all of us want to, one, compliment you for organizing this event and also thank all the professors and the audience who have so patiently been through the day. And we learned a lot. I learned a lot, and I'm sure some of the others did also, and especially the young medical students. So thank you for this opportunity.
Thank you.
Thank you.
Ο φωτογράφος, παρακαλώ, πού είναι? Α, με συγχωρείς. Καλά, later on, take a picture of the 7 wise men and later on.